Good morning, delegates, faculties, and participants. I welcome everyone on this pleasant morning. I welcome for this BLS Preeclampsia Series 2, Episode 6, Placenta and Preeclampsia. I get immense pleasure to introduce Dr. Akshita ma'am. Dr. Akshita is a consultant, Manipal Hospital, Malleshwaram, Bangalore. Ma'am is a life member of various societies. To name a few, Bangalore Society, IMA, and Society of Maternal Fetal Medicine and PCOS Society of India. Ma'am has a good academic and professional contribution. Ma'am received a lot of awards and achievements in patient care and maternal health initiatives. Now I hand over the session to Dr. Akshita for the further proceedings.
Thank you, Ms. Chitrakala, for this wonderful introduction. Namaste, everyone. I'm Dr. Akshita here. I welcome you all to the Virtual Learning Series 2, Episode 6 on preeclampsia. Today, we will be learning about placenta and preeclampsia. We will first have the welcome address, followed by a lecture by Professor John Kingdom. Then, then the panel discussion, the capsule on placental pathology. And today, we also have a special launch of the special interest group for HTPP. So stay tuned for an enriching learning experience today. I now welcome our President of Society of Maternal Fetal Medicine India and Chairperson for today's session, Dr. Prakash Mehta, sir, to deliver the introductory and presidential address. Welcome, sir.
Good morning, everybody. It's always a pleasure to be on a VLSPE series. This is a series that have been formulated by the Society for Maternal Fetal Medicine India to ensure that a continuing education for the preeclampsia goes on. Today's session, and each of these VLSPE sessions, we have had stalwarts from across the world coming in to participate, and so that our delegates learn straight from the horse's mouth. Today's session, we have very important faculty coming in from Canada as well as from Australia. And we will be learning directly as to what exactly they are doing in their country and whether we could follow it in our country and ensure that our women get a better health care. At the same time, today is a very special day also, in the sense that we are having an inauguration of our special interest groups. Our preeclampsia special interest group, everybody is very well aware of. And we are also planning to have special interest groups in preterm labor, nutrition, and labor. These sessions are open to anyone who is interested, and we would welcome even participation from anyone across India and across the globe who would like to take part in this kind of programs. So with this, the Society of Maternal Fetal Medicine has reached great heights. I have to thank my secretary, Dr. Revati Rajan, for doing a lot of hard work. We have already released the book on preeclampsia, which has been received extremely well across the globe. We are already started formulating for the second edition for that book. And we also had recently our annual day, which also was a great academic feast and success. And as a young society, without, I should say, the cost of not being humble, I must say that we have done extremely well. So that is courtesy to all my young co-members that are present, as well as the delegates who make it a point not just to attend a live session, but also, the YouTube hits that we have had for each of these sessions are really phenomenal. So please continue doing that. And it is with your encouragement that we can do better and better in the field of women's care. Thank you very much for being there today. And with this, we proceed on with the session.
Thank you very much, sir, for your encouragement and kind words. I now would like to introduce Dr. Sangeeta. She's a consultant in Cloud9 Hospital, Bengaluru, to say a few words about placental biomarkers before we move into Professor John Kingdom's talk.
Good morning to one gathered here for this August occasion. As we all know, preeclampsia is a very major contributor to maternal morbidity and mortality and has risen to the leading cause in India. In the Indian context, it affects about 10 to 15% of pregnancies. And today we are going to do a deep dive into learning the role of biomarkers in the prevention and early detection, pro-angiogenic and FMS-like tyrosine kinase SFLT1, respectively, circulate in maternal blood system and are altered in pregnancies that are complicated by preeclampsia, fetal growth restriction, preterm delivery, or stillbirth. And the imbalance of these two contributes to the clinical manifestation, and alterations in angiogenic factors can often be detected before the onset of clinical symptoms, which is why it's important for us to understand this. Placental growth factor stratifies patients by the which is less than 12 picogram per ml, low gram per ml. And a very low PLGF suggests very severe placental dysfunction and increased preterm risk, while a low level indicates placental dysfunction and increased risk for delivery. Increasing levels of SFLT1 and decreasing levels of PLGF ratio are a useful tool for predicting or diagnosing the role of the biomarkers in this context. Thank you.
Thank you very much, Dr. Sangeeta, for that quick, brief introduction on biomarkers. Now we will have a lecture by Professor John Kingdom. It's a second talk on the clinical utility of placental growth factor test in prediction and prognostication of PE and importance of placental clinic after the introduction by Dr. Sangeeta. Professor is from the University of Toronto. He has made remarkable contributions to placenta-mediated pregnancy complications. He's introduced real-time maternal placental growth factor testing. He's been working on this since 2017. This into clinical screening, diagnosis, and management of preeclampsia. He's pioneered PLGF testing in North American clinical practice via the Placental Clinic. He has mentored numerous trainees whose work won awards on advanced placental science. This lecture will go on live now.
So in this second talk, we're going to go through sonographic placental development and go over the integration of PLGF information with it for precision diagnosis and care. We're going to utilize information from the first talk in sonographic diagnosis of maternal vascular malperfusion disease before delivery. So introducing the notion that you can actually make a placental diagnosis before delivery rather than waiting for the placental pathologist. That's actually going to be important in the future, and that we can make these diagnoses earlier, then we can have much smaller trials of additional medications that could be effective other than, for example, low-dose aspirin has some effect, of course, in this condition. And then the final part of this talk is how do you recognize the non-MVM pathologies? Because those are differ dramatically in their pathogenesis and recurrence risk. And so placental pathology becomes fundamentally important in counseling patients. So I will also go over my approach on how to counsel and manage patients by each diagnosis in the future. So first thing from that review article that I put up at the end of my first talk, the perfect normal placenta has a central cord insertion. And the reason for that is that the blood vessels will dichotomously branch in all four quadrants. Dichotomous meaning that at each branch point, the vessels are going to branch again at 90 degrees. That results in the most efficient penetration of the chorionic plate to form the placental villi beneath the chorionic plate. So the ultrasound probe is rotated around the cord, which is centrally placed. The placental length should be broadly similar through the 360-degree rotation of the probe. On the right-hand side is indicated measuring the placental length at the basal surface in contact with the decidua, which we have found to be more reproducible, and we've built a reference range around that. Some degree of asymmetry of the disc is quite common and a normal variant, and therefore there can be differences in maximum length at 90 degrees to each other, which is really not actually that important. So what are the sonographic findings in placental MVM disease? Well, the first one is to look at the number of cord vessels. A two-vessel cord is classically associated with placental regression, and you can see umbilical artery thrombosis occur right through human development. It can even result in stillbirth if acute thrombosis occurs in the third trimester. But excessive chorion regression in the first trimester can turn a late embryo with a three-vessel cord into an early fetus with a two-vessel cord. That's the first thing. The second thing is the basic shape, length, and thickness of the placenta. I was telling you that the anchoring villi keep the chorionic plate and basal plates parallel to each other, and therefore retains the normal shape of the placenta, where the chorionic plate is flat and the placenta will taper at both ends. You can see the tapering here. And the thickness, I'll show you, grows a little bit during normal pregnancy. But it's important to understand that excessive placental thickness has a number of different causes and is a very poor prognostic sign. And the next thing is the placental texture. With diseased spiral arteries, intermittent or abnormal maternal blood supply can result in pathological injury to the placental villi, and this is classically placental infarction, but there are a variety of injuries that may be visible by ultrasound that indicate progressive damage to the placenta, and therefore, for example, it might be a good idea to check the uterine artery Dopplers, and even more, a good idea to measure their PLGF level. And the final thing, as stated, is to check the perfusion of the uterus on the maternal side using the left and right crossover uterine. So what are the sonographic findings in placenta points here? Here is color Doppler on the center of the placenta showing two blue jets from the umbilical arteries. So therefore, this is a central normal three-vessel cord. Points here. Here is color Doppler on the center of the placenta showing two blue jets from the umbilical arteries. So therefore, this is a central normal three-vessel cord. And there is the classic crossover point of the external iliac and the anterior division of the internal iliac, which is the dominant vessel coming up alongside the uterus as the uterine artery. And that's the typical high flow velocity, high diastolic flow, low PI. Look at the PI, 0.67, typical mid-trimester normal uterine artery Doppler waveform. And here is the normal uterine artery Doppler mean PI pulsatility index reference range, an example of one. This is not our reference range, but in the green line you can see our reference range between week 60 and 22 from a research we published in the Green Journal in 2017. Uterine artery Doppler is popular in the first trimester as part of complex first trimester screening for prevention of preeclampsia. But the vessels can be hard to obtain, and many research studies in this area actually adopt vaginal ultrasound in order to obtain the vessels accurately. And we actually do not do that. We start uterine Doppler assessments at week 16, which is much easier transabdominally, and it leaves enough time to commence aspirin where they're not normal, and we're concerned about preventing preeclampsia from MVM disease. Where I contrast then patients who have high pulsatility index in the uterine arteries, and you can see the classic early diastolic notching persisting from the non-pregnant and early pregnancy state. So this chronic ischemia reperfusion injury will produce not only a small placenta with an eccentric and or two-vessel cord, but on the right-hand side is going to produce some degree of destruction in the placental tissues. There's an example here where this placenta is thicker than normal, the cord is eccentric, it's fixed and sliced open, and you can see on the right-hand side, multiple areas of clear tissue injury. So what types of injury can be seen on ultrasound? Well, the first one is that these solid infarcts may be visible. But I would freely admit that placental texture sonography is not that accurate, and a limited number of studies have done correlating ultrasound findings with pathology delivery are not very reproducible unless the findings are very dramatically abnormal. So in my practice, I'll sometimes say that, for example, here there's evidence of multifocal infarction. But where I don't see anything diagnostic, I'll say the placental texture findings are non-diagnostic, and that's the case for most patients. These are intravillous thrombi, and the villi are compressed, producing an irregular rim around the edge. And what these structures indicate is microinfarction that bleeds, and means that there's probably abnormal uterine Doppler and probably therefore also low PLGF levels. So when these are seen in multiple areas of placental tissues, it's probably a good idea to check the uterines and PLGF. You can also see, we'll come in a second, this placenta in the fundus is a lot thicker than normal, and we're going to come to that in a minute. So placental length from week 20 to 24 increases slowly from about 17 up to around approximately 20 centimeters in length using the curvilinear approach on the basal plate. And you can see the fifth centile going to rise from 14 to 16 centimeters. As an example of the extent of placental regression seen in this disease, we published a paper where we looked at patients with placentas less than 10 centimeters of maximum length, shown in the next slide. On the right-hand side, you can see that dramatically less than the fifth percentile for gestational age. And when patients have bilateral abnormal uterine artery Doppler flow patterns, they're much, much more likely to have a small placenta for gestational age, which is the hallmark of MVM disease. This is, therefore, the link between abnormal uterine Doppler and the disease. The placental regression then can produce these sonographic findings. Top left-hand panel is to identify a very eccentric cord insertion. You can see this placenta is relatively small and quite thick. In fact, its basal length is similar to the width of the placenta associated with that cord on the margin. That's straight away MVM pathology, even without checking the uterines. And below that, you can see a single umbilical artery. Where you see a single umbilical artery, a lot of people focus on the kidneys to make sure that there's look for a renal tract malformation. It's also important to go looking elsewhere for the other reasons why you may have a two-vessel cord, like severe MVM disease. And there is an example from this patient with an eccentric cord and placental regression. These things are important to also to understand placental biomarkers. So certainly in Canada, we still retain EFTS testing, although I do suspect that over time this is going to be abandoned in favor of NIPT, which has become much more fastly adopted widely in the United States and in many European countries. But I just put the slide up to show that, in fact, the biomarkers used to derive a risk for Down syndrome are all placentally derived proteins. They're not great in terms of predicting adverse outcomes from positive predictive value, but the best of the bunch is PAP-A. PAP-A is really, in maternal blood, is an expression of the surface of the placenta. And the surface of the placenta here is dramatically smaller, as shown with the blue vascularization compared to the red circle of where it should have been developmentally. So you can imagine that this maternal blood sample will have low PAP-A, indicating significant placental regression already evident at the end of the first trimester. Here's another example where not only is PAP-A low, but in fact the PLGF levels are very low. So in fact, I'm talking to this patient with my own handwriting to say that I don't think with a normal nuchal translucency that the baby's at risk of trisomy 18, and it's far more likely to be a placenta problem than a baby problem. Let's send you down the hall for a placenta blood test, and that's exactly what we did in this patient. For those of you who are more interested in this, actually, we published a population-based study of the utility of these biomarkers in hypertension from Ontario. And we filtered through the records down to just over 250,000 pregnancies, singleton pregnancies linking EFTS biomarkers with pregnancy outcomes. And we derived the relative risks of adverse outcomes by biomarker. Now, low PAP-A in black is in the standard first trimester screening, and combined with PLGF in the E or enhanced first trimester screening. I want you just to see here from the top running down is that the black and the gray dots are pushed over further to the right, for example, with preeclampsia in early birth or birth weight less than a third centile or preterm birth less than a third centile. But generally speaking, PLGF is the best of the bunch, but the positive predictive value for low PAP-A for these outcomes might be at best 5 to 6%. So what about placental thickness? The first thing to know is that placenta will slowly increase its thickness over time from the time of the anatomy scan, and a good rule of thumb is 1 millimeter per week of thickness. A second rule of thumb is that 4 centimeters thickness is the upper end of normal when the baby becomes viable, so long as there is not a uterine contraction, because when the uterus contracts, it will distort the shape of the placenta. So the placenta looks abnormal. The first thing to do is just make sure you're not dealing with the uterine contraction and wait until it goes away. So you can see the rise in the average placental length goes from 3 to 4 centimeters over the course of a month from weeks 20 to 24. Keep in mind this value of 4 centimeters being upper end of normal. Here's an example of a thicker placenta. There's a patient with very low PAP-A, an eccentric 2-vessel cord, and turns out placental thickness is pretty similar to the surface area in contact with the uterine wall. It's just, again, chorion regression. Here's another patient with a 6 centimeter thick placenta with a cord insertion point, not shown very well, but on color Doppler at the edge of the placenta in a patient with a high maternal serum AFP historically at week 16. What's happening here is that the anchoring villi I told you about that normally keep the chorionic and basal plates together, this is shown in panel A in vivo, that in a normal placenta, the chorionic plate always stays parallel to the basal plate, and it will collapse a little bit at delivery. But in patients with severely abnormal placental villi and areas of infarction, the anchoring villi break apart, and therefore the bag inflates full of maternal blood, causing placental hyperinflation. And that can be 5 or 6 centimeters thick. You'll see some videos in a minute. And it will completely collapse at delivery and be thinner than under normal circumstances because of the hypoplastic and underdeveloped placental villi. And this is called placental hyperinflation. And here's a video of this. That placenta is about 7 centimeters thick and is jelly-like and wobbly because it's a bag of maternal blood. It's not 6 centimeters thickness of. Here's another example which is quite dramatic. To your left-hand side here in the uterine fundus is the placental tissue. Over here, this is bulging right out into the amniotic cavity, and this is maternal blood just sloshing around in the intervillous space. To the right-hand side is the amniotic fluid, and then what happens is that the baby's knee is kicking the placenta and coming into view transiently during the loop of the video. Again, a dramatic example of a ball-like placenta. Sometimes I've seen referrals where these are considered to be fibroids because nobody's actually deduced that there is not a separate healthy normal placenta. This is actually the placenta. Here's another example of a very thick placenta. Again, another variant of MVM pathology, where the bottom here is the normal placental tissue on the posterior wall that's being crushed by this big, thick layer of blood. This is not blood flowing slowly. And it's shown here under sectioning, under gross. The pale stuff is the placental tissue. The dark stuff is all the hemorrhage under the chorionic plate, shown here on the right-hand side in gross pathology. So I told you in normal circumstances that PLGF rises during normal pregnancy, and this is a typical profile of PLGF rising when the uterine artery Doppler is normal, because the spiral arteries are correctly perfusing the placenta with oxygenated blood at low pressure. And so the placental tissues are nice and happy.
Just ask Chitrakala to message us once it is sorted.
But where there's bilateral abnormal,
Talk to Sahiti also.
an early start to develop PLGF with enthusiasm is then curtailed over time by repetitive areas of injury and infarction that then stall the rise in PLGF and then starts to fall away. This is a classic PLGF profile in patients with MVM pathology. And once the PLGF fails to get above 100, the patient is then at risk of severe preeclampsia and severe growth restriction. It's just a severe example where it would present with pre-viable growth restriction at 300 grams and reversed end diastolic flow, just a non-viable pregnancy, just an extreme example. So in summary for MVM pathology, comparing panels A and C in green that are normal, placentas with MVM, patients with MVM pathology classically have A, bilateral abnormal uterine Doppler, B, low PLGF levels, and C, variants of disordered placental anatomy consistent with the gross features of the MVM pathology. People often ask me, well, which is more important, looking at the placenta or the uterine artery Doppler? And the answer is the vast majority of situations, uterine artery Doppler alone, if you're going to do one thing, is more useful. Occasionally, patients will have a dramatic diagnosis like Breas mole, and the uterines might be relatively normal. But most of the time, uterine Doppler is the key observation in the absence of PLGF testing. As I'll show in the remainder of the talk, the king test is PLGF, the queen test is uterine Doppler, and the last in the row, the joker, is placental morphology. This is one publication we had, I think 300 patients, showing that when a uterine Doppler is abnormal, there's no additional predictive capacity of placental morphology in the vast majority of patients. One area where PLGF is actually super useful is navigating abnormal EFTS testing. Because a lot of patients have abnormal EFTS biomarkers with low positive predictive value. They get sent to MFM. It's very time consuming to manage them. And our new protocol is to do a PLGF test first. And that can be done by the referring physician. And we refer patients where the PLGF is low and or the patient has a complex medical and or obstetrical history. Right, let's move on then to the sonographic findings in the patients with non-MVM pathology. Let's start with a case study. Here's somebody who has had a previous 26-week stillbirth without any placental pathology, and she had no hypertension, and it was extremely growth-restricted baby. Here in the next pregnancy in referral, when we look through the chart in referral, there's a multiply abnormal EFTS sample with a normal NIPT, the classic combination of placental insufficiency. In these kind of patients, they get a PLGF blood test before they even see me on the same day. So PLGF is dramatically low. But here with absent end diastolic flow and a small baby, we have normal uterine artery Doppler. And so this stumps clinicians for two reasons. First of all, in many patients in this situation being evaluated in units around the world, there will be no measurement of PLGF. And it's not uniform that patients will always have uterine artery Doppler done. But I would contend to you that both of these tests need to be done to truly appreciate what's going on. This patient has severe placental disease causing it to be a growth-restricted baby. It doesn't have a fetal abnormality. It also does not have MVM disease because the uterines are normal. And I've deduced that in the first 10 minutes of the patient being with me. And therefore I can focus on managing a patient at risk of HELP syndrome with low PLGF rather than asking her to have an amnio and wait 3 weeks for a WES result, which is going to be useless. Okay, so what is the diagnosis there? Well, we're trying to therefore find patients at risk of severe non-MVM pathologies, which I showed you before, where CHIV and massive periolus fibrin deposition as shown here. To understand this better, I do recommend reading this paper we published in the American Journal in 2022, and I'm going to go through the main points of this paper relevant to this talk. So the first point in this talk, this is actually the outcomes of about 350 patients, each with a specific placental diagnosis, shown categorically here as all the ones we've been talking about. The first point is that the proportion of patients with clearly abnormal, bilateral abnormal uterine Doppler is far higher in patients with MVM disease than any other disease. Second thing is some patients have more than one disease, which is why the MPFD rates are intermediate for abnormal uterine Doppler. But the important point is bad uterine Doppler is pretty much associated with MVM pathology. So the uterine Dopplers are perfectly normal. We have to sort of figure out which of these diseases the patient might have. Let's talk about the most common of the rest of them then, which is fetal vascular malperfusion. So first up, early placental development is normal. Uterine Doppler is normal, therefore the blood pressure is normal. There's however, a very wide spectrum of presentation, from sudden fetal death right through gestational age, an acute reduction in fetal movements, early or late onset growth restriction, perinatal stroke, including the patient I showed you with an abnormal arm, and antenatal origin cerebral palsy, where gases are normal at birth. First thing is these patients often have hypercoiling of the cord, probably 80% of them. And it can be measured by measuring vein to vein or artery to artery, and that gap divided into 10 is the number of turns per 10 centimeters. In this case, with 1.8 centimeters between the turns, that's 6 turns per 10 centimeter. Normal is 2 to 4 turns per 10 centimeters. So this is a hypercoiled cord. There is another example dramatically in grayscale. You can see the busy arteries winding the array around a straight vein, and it becomes much more obvious on color flow mapping, where essentially the cord is entirely wrapped with the umbilical arteries. The reason this is important is that cord coiling is directly related to cord length. The longer your cord, the more likely you are to get it trapped, either, as in this case, 4 or 5 times around the baby's neck, shown in color Doppler flow scanning. It can also be trapped around the body or the lower limbs. Here, despite the fact the cord is around the neck, you can see some evidence of skin indentation, but the umbilical artery Doppler flow pattern remains quite normal, as was the brain flow pattern. But sometimes it's important to counsel these patients regarding fetal movement counting intensively. These are the patients that really need to have it done. Here's a patient back 4 days later with a nuchal cord that goes from having normal umbilical artery Doppler to suddenly having minimal diastolic flow at 34, 35 weeks. Very unusual thing to happen. So you've got to go finding the cord obstruction. And here, look, it is. There's indentation of the skin below the knee of the baby. There's the knee, down the leg to the foot. It looks like there's umbilical cord associated with that limb, which then is now identified wrapping around the lower limb on color flow Doppler scanning. Very interesting. And these patients have got a significant acute stress on gas exchange. So they get hypercapnia and will have high peak flow. Look, the PSV is 86 centimeters per second. The rough rule of thumb is GA times 2. So 34 weeks, that should be no more than around 70. So that's really very significantly high. And this notching in the middle cerebral artery is highly abnormal. You never normally see that. So this is a patient with acute cord obstruction. And it's very rare to capture abnormal ductus venosus Doppler in late pregnancy. So you can see a dramatically distressed baby that was I just delivered it straight away by cesarean section. So prenatal diagnosis of FVM, how do you deduce it clinically? Number one, they're always clinically low-risk patients because it has a sporadic disorder of the cord anatomy. So they have normal EFTS, normal blood pressure, normal uterines, placenta look normal. Generally speaking, their PLGF levels are normal unless there's multiple areas of avascular villi that ultimately overwhelm the placenta and cause low PLGF. And on sonographic examination, the umbilical cord is crowded in the amniotic fluid. And if you look carefully with color flow, you can see that it's obviously very hypercoiled. You can't measure the length. That's the deduction that says to you, this early onset growth restricted baby does not have MVM, it has FVM. And here you can see in blue is the profile of circulating PLGF levels over time on the x-axis by a diagnosis with the 10th and 50th centiles shown in the notched blue. So profile of PLGF levels is generally normal because it just takes a sufficient block of the umbilical cord to kill the baby. Or intermittent blockage causes subtle degrees of typically late onset growth restriction. So counseling for the next pregnancy is it's sporadic, therefore low recurrence risk. So what I do for these patients, because they're anxious, is I'll do a negative predictive value scan, which is at 16 weeks, I can see the cord very clearly. It's not going to get hidden by the baby. So I'll check the cord at both ends, making sure that we don't have a marginal cord or a kinked cord at the fetal end with turbulent flow at the insertion point. I'll make sure the cord isn't hypercoiled. And then I'll bring it back at 22 weeks, and I always check PLGF uterines and placental anatomy because MVM is, I want to make sure they don't have MVM disease either. So I can reassure them they haven't got MVM or FVM by the time they're 22 weeks pregnant. Now, what about VUE? VUE also causes late onset growth restriction, typically without blood pressure problems. The difference from FVM is it has a high recurrence when it's high grade. So these patients in another pregnancy will typically have normal EFTS, normal blood pressure. The patients are typically older. It's more common with maternal age, as is MVM pathology. The uterines are normal, placenta looks normal. The PLGF is normal early on, and the umbilical cord will look normal. It's not hypercoiled. So by deduction, you can tell the difference from FVM. VUE is a progressive, slowly progressive, late onset disease. It's not going to cause, it does not cause early onset growth restriction. So counseling for the next pregnancy is you do have a high recurrence risk because of the following. T lymphocytes are not meant to get in the placenta, and the decidua has molecular mechanisms that actively prevent T cells from entering the placenta. So for genetic or acquired reasons, the endometrium becomes incapable of preventing T cells from evading it, which is why there's a 30% recurrence risk. But it's going to cause late onset growth restriction. So it's a slow disease that's progressive. It's therefore recognized primarily by serial ultrasound for fetal growth, where I would always include CPR Doppler of the brain. And I would start PLGF testing later. I might do a 22-week MVM exclusion examination, so morphology, uterine Doppler, and PLGF, but I expect it all to be normal. But the key points would be fetal growth and PLGF testing at 36 weeks. And then at 36 weeks, decide when to deliver it. So we had the patient with that previous history and their PLGF was, say, 60 at 36 weeks, and we had a drop in centiles. I just deliver the baby a week later because we have indirect but clear evidence of recurrent VUE disease. Okay. What then about the two nasty ones that are rare, MPFD and CHIV? Well, the first thing is they are severe diseases with a very high recurrence risk of about 50%. So they'll generally present with a history of normotensive stillbirth or early severe growth restriction, peri-viable or infant alive requiring neonatal intensive care. Mostly they don't have hypertension. Classically, they will have been navigating multiply abnormal EFTS testing, so they'll tell you that, and they'll have had NIPT that's normal. They may have multiple failed attempts at NIPT due to low fetal fraction from an early significantly damaged placenta. Uterine Doppler is normal. Early placental morphology is normal, but the classic difference is their PLGF never increases. It's low from the get-go, and they will develop periviable growth restriction. So they're shown in the profiles in red and orange, shown here at the bottom end. There are very few patients left at 28 to 32 weeks because of the attrition rate, but the difference is they have the lowest PLGF levels early on and they do not rise. So the combination of early, very low PLGF, bad previous history, normal ultrarotary Doppler, it smells of CHIV and or MPFD or both in combination. Have counseling for the next pregnancy are that this is a highly aggressive diseases with early first trimester onset, therefore multiply abnormal EFTS testing. There's poor quality evidence on treatment because they're very rare events. I'm a little restrained in what I do for MPFD. I'll do aspirin and heparin from week 8 and add in hydroxychloroquine twice a day orally. For CHIV, the patients often have a very aggressive history, and we are using the London, England protocol of adding tacrolimus to follow the analogy of renal allograft rejection. An alternative viewpoint is to use steroids, but steroids are complicated and have a lot of side effects, cause diabetes and immunosuppression. I am not a fan of them. So our quad therapy protocol for CHIV is aspirin and heparin from the get-go, adding in hydroxychloroquine and layer in tacrolimus by week 10 to 12, which requires blood monitoring. I don't do that alone. I do that with a nephrologist. So I just thought I'd finish off this evening with some thought-provoking conclusions and thoughts. So the first one is this. You now understand why PLGF is superior to ultrarotary Doppler to predict early intrauterine fetal death. From our study in the American Journal, ultrarotary Doppler could predict 21 out of 29 cases, but low PLGF predicted 28 of them. And you understand the reason why. It's because PLGF captures the full range of placental diseases that cause early onset growth restriction in stillbirth, i.e. all of the non-MVM diseases. That's point number one. Point number two, in maternal fetal medicine practice, I predict, and this is our experience, that early serial PLGF blood testing can profoundly predict the prognosis for pregnancy into these kind of categories that then tell us about where a patient's care ought to be. It can be democratizing because the blood can be sent to an MFM centers to decide which patients need to travel extensively for higher order care. And I don't need to tell you in Australia that you have the same geographic challenges and concentration of urban high-quality medical care. And this is a big issue for rural patients. So I believe that PLGF testing is a very powerful tool to provide health equity for patients living in rural communities. Now, the second thing is, just before I came to visit you in November of last year, we published our huge screening study of 10,000 patients in mid-pregnancy with PLGF screening, and the intent there was to find 1 or 2% of patients at risk of mostly MVM disease and manage them really well. In other words, manage their risk of hypertension and provide high-quality fetal surveillance for growth restriction. So we did that in this study, and we maintained a stillbirth rate after 28 weeks of 1 in 250 during the massive COVID crisis. Now, what's interesting, I've just finished, but it's not published, an in-depth analysis of all 36 stillbirths in this cohort. The most common cause is fetal vascular malperfusion. Why? Because the patients are asymptomatic. Secondly, it's the patients have normal circulating PLGF, so they will be screen negative in this study. What's very interesting is we take a really hard look at what truly is preventable. My view is only 9 of our stillbirths were truly preventable, which is a rate of 1 in 1,000. Like a 1 in 1,000 rate of preventable stillbirth is actually pretty impressive. Now, there were 2 MFM cases, MVM cases. Most were largely eliminated, but in fact, ironically, both cases of patients with stillbirth and MVM disease did not follow care and had subsequent stillbirths with abruptions. And the other sad event in modern medicine is the second most common cause of stillbirth over the 3-year period for us were tragedies of intrapartum care trying to deliver vaginally in patients with extremely high BMI. These patients almost certainly should be delivered by electrocesarean, but not all patients want that, and they obviously will have their choice. But it saddened me to see that, and I was directly involved in one of them and could not prevent the stillbirth. It was a very, very difficult situation. So then I want to show you this painting from 1743, where you can see the baby is being examined and it's holding its cord to tell everybody why it died from fetal vascular malperfusion. And I've just put it from 1743 to this year to say that with more effective PLGF screening diagnosis and PLGF-directed care, we're going to have a big bite in the disease that we call preventable stillbirth, leading then to a residual rate of unpreventable stillbirths from lots of different reasons, the most common of which now today, again, is fetal vascular malperfusion.
We thank Professor for giving his valuable time, the meticulous explanation about sonographic findings of the placenta, and clarity in addressing the PLGF test. Now, we move on to a special launch today, for which we have representation from the SMFMI leadership, Dr. Prakash Mehta, Sir, our President, Dr. Revati Madam, our Secretary, and we have leaders from the Australian New Zealand Preeclampsia Network, the APN, Professor Amanda Henry, Professor Natalie Henin, and Professor Renuka Shanmugalingam. Thank you for being with us today. I request Dr. Revati to say a few words on SIG and HTPPE. Chitrikala, can we have the slides on the SIG, please?
Thank you so much, Akshita, and welcome one and all. We are very glad from the SMFMI to be launching the special interest groups in the maternal fetal medicine perspective. So today we are going to launch the special interest group based on HTP, hypertensive disorders in pregnancy, and preeclampsia. However, we are planning to be launching the SIGs on preterm birth, nutrition, labor and delivery, and Suraksha, which basically concentrates on patient education in the near future. Next slide, please. Next slide, please. Yes. Now, what is the need for special interest groups? Now, special interest groups in maternal fetal medicine have been introduced for catalyzing innovation and collaboration. This launch is coordinated by the Society for Maternal Fetal Medicine India on 17th August 2025, which is today. And this group focuses on distinct academic and research domains, aims to improve health outcomes for pregnant women and unborn babies. And this is a structured framework for leadership continuity, academic ownership, and resource allocation. Next slide, please. Now, what are the key features and benefits of SIGs? There is a structured leadership with clearly defined roles, long-term commitment with a 5-year tenure, academic ownership and autonomy, dedicated operational support with research and administrative assistance, centralized but transparent funding, flexibility in execution with no minimum project requirement, opportunities for interdisciplinary work, global engagement, and public health integration. SIG membership is exclusively available to SMFMI core members at no additional cost. So I urge that all of you who have joined us can actually seek SMFMI core membership to work as part of the SIGs. Now, what are the chief objectives of special interest groups? It is to innovate, collaborate, advance, improve, and transform. And with this, I request Akshita to proceed with the launch. Thank you.
Thank you so much, Dr. Revati, for that brief introduction on what the SIG is and how we are going to go about it. And now I request Dr. Prakash Mehta, sir, to say a few words before we proceed to the formal launch.
Good morning, everybody, and welcome to this session again. The special interest groups we have been thinking for a long time. Revati initially took a lead by starting for the preeclampsia, and then we thought that in India we have a lot of other really worrying factors like increased incidences of preterm labor, the poor nutrition, of course, is always there. And we also wanted a community-based program, and we named it as Suraksha. Suraksha is a Sanskrit word which means, safety. So we wanted to provide some kind of a safety net for the women out there, and that's why this program came into being. And again, I repeat, like what I said in the morning, I have a team of very young doctors, highly enthusiastic, very academically oriented, and they're all ready to do a lot of work for this program. And so we thought we should have, the special in varied fields. Today, we are very happy to say that we are going to start with the special interest group in hypertensive disorders of pregnancy. And the flagship project for this particular special interest group is the Preeclampsia Education of Nation India, the PENAI program, which by now has already certified 1,000 obstetricians across the country and in many of the South Asian countries, including Pakistan, Afghanistan, Bangladesh, and even some from the Western countries also. We are planning to go further global with this particular program, and the special interest group will possibly help us to take it, across various countries. Maldives is the one country where actually Revati had already gone there and spoken once, and we are planning to spread our wings into that country also. Our aim is just very simple. With whatever is available at the ground level, no hi-fi talk, technology is not available in quite a few countries in this world. And with whatever technology is available with them, it need not be very hi-fi. What they could do with simple clinical work and how to save those women, especially from the hypertensive disorders of pregnancy. We now know that postpartum hemorrhage was the commonest cause for maternal death in India a few years back. Now, preeclampsia is the commonest cause for maternal death. So unless we tackle preeclampsia, we won't be able to bring down our maternal mortality further. No doubt we have improved a lot. Like when I was an undergraduate, the maternal mortality was 600. When I became a postgraduate, it was 400. When I started practice, it was 200 and odd. And today we are staying around 60 to 70, with some states clocking also 15 to 20. So we have improved a lot, but there is scope for a lot more improvement. And this program, I hope, with the participation from doctors all across India, we would be, definitely successful in bringing down the mortality. I'm also very happy to state that we have a lot of global giants, I should say, supporting us. We initially started with Dr. Renuka from Australia. Of course, Dr. Sarosh Rana from the US has always been with us. But Renuka was one of our another points who helped us to get in touch today with Professor Natalie and Professor Amanda. And I'm sure that we will have further cooperation and further work being done, maybe together, and see that we bring down the mortality rates for the mothers. So thank you very much. And with this, we go further.
Thank you very much, sir. We'll now play the video and request the leaders from SMFMI and APN to launch the SIG. Thank you very much, sir. I request Professor Renuka, Professor Menda, and Professor Netley to kindly share their experience of formation, setting up, and functioning of APN, which is strongly influenced us to form the SIG with HTP-PE. Professor Renuka? Yeah, Professor Menda.
Yes, thank you very much. So sorry, I'm hopefully sharing those.
We can see your presentation.
Yeah, and sorry, slides. Yes, is it in the right thing now? Yeah, lovely. So thank you so much for the invitation for the three of us to come along and talk to you today, and huge congratulations on setting up your special interest group. So I'm an academic obstetrician from Sydney in Australia. Professor Hannon is a scientist based in Melbourne, and Renuka is an obstetric physician also in Sydney. So we together, I hope, sort of represent the sorts of things that make up the preeclampsia network in Australia and what we're sort of all about. I just wanted to give a little bit of background about sort of our network and its relationship to our societies in Australia, because every region does sort of things slightly differently in how their obstetricians, their physicians, their scientists, and people interested in maternity care and preeclampsia work do things. So our main society is Obstetric Medicine of Australia and New Zealand. There's also separately both the College of Physicians, which SOMAT sort of falls under, but not quite, and also the RANZCOG, the Obstetricians and Gynecologists, which is college as an obstetrician, and we have our own maternal fetal medicine subspecialty as well. But the society really is what brings us all together. And it was formed in 2004, so a bit over 20 years ago now, from the previous Society for Study of Hypertension in Pregnancy in Australia and the Obstetric Medicine Research Group of Australasia. So we obviously had strong underpinnings of hypertensive pregnancy work and research previously. So SANMANS is a multidisciplinary society. A bit over half of its members are physicians of various kinds, usually, of course, with a special interest in pregnancy medicine. About a third of the membership are obstetricians, and then we have midwives, scientists like Natalie, anaesthetists, and others with interest in the medicine of pregnancy. And lots of our members do have strong hypertensive pregnancy research and clinical interests. But about 10 years ago, we wanted to bring together a dedicated group in terms of this. And so we had our first sort of semi-official APN meeting alongside our 2015 SOMATS ASM. Since that time, we've had full meetings about every 2 years. We have had one standalone meeting, but mostly we've actually found that it works better alongside other obstetric or obstetric medical events. And for the last couple of big meetings that we've had, it's been part of the SOMANS meetings. And in fact, some, I believe, of our Indian colleagues were actually at our 2024 APN meeting, which was held in collaboration with the ISOM Congress. So thank you for those who came. And essentially, APN is an opportunity for clinicians and scientists and community representatives to come together to talk about work, to discuss proposed work, to discuss potential collaborations and review our priorities in preeclampsia and HTP research and advocacy. And we're now in the process of actually becoming a formal special interest group of SOMAT, since that's really where we align. And so we've done a few different types of meetings over the years, and one just to show in terms of from little things, big things can grow. This was my own work that I pitched sort of 8 years ago now about an early intervention trial in the first 12 months after hypertensive pregnancy, currently under second review with the Lancet, all fingers crossed. And that, a year later got funding, and I actually had the honour of presenting the primary results of that study at the ISHIP Congress in Bangalore 2 years ago now. And I have to say, in terms of personal sort of work as well, Natalie and I kind of met through APN and have kind of built up a joint kind of program of work. So yeah, it is very helpful. And then just a couple more happy snaps really. So this is just as we were coming out of COVID. This was the first face-to-face meeting for most of us after COVID, and we met in Hobart alongside the SOMATS meeting, and we do have a good time as well. That's some of us at the dinner afterwards, that's part of the program from there. And so we try to do a combination of keynote type addresses, a chance for people to pitch, particularly our early and mid-career researchers, and then discuss what our priorities, are between now and the next meeting. And then that's, yes, our meeting from last year where a few of you are at, and I will hand over to Natalie now.
Thanks so much, Amanda. And it's really great context because where we've come from and where we're going is what I'll touch on now. So Amanda's already introduced the fact that I'm a scientist and Amanda's an obstetrician. And when we wanted to think about what the future of APN looked like, we wanted to really ensure that we really instilled that sense of scientist-clinician collaboration would take us the furthest together and have the greatest impact in our research. And we believe that's because we're really thinking about how we bridge fundamental discovery in the laboratory, but also what's happening in practice or in clinic. And we know that this just means that we'll have the best cutting-edge discoveries or science, but also being rapidly translated into clinically relevant diagnostics, maybe risk stratification tools, and also novel future therapies. So I'm sure I don't need to tell this audience, but the clinical context here for our research is that the scientists need that input from clinician real world problems and really thinking about patient needs as well, so that it can guide us in the laboratory as well to thinking about the most important clinical challenges and how we might utilize that in thinking about preeclampsia during pregnancy, but also the longer term cardiovascular health concerns that we have for these mothers and their children. And also thinking about integrated pathways to impact. And we think that joint leadership and that shared leadership is really going to move us the furthest forward as quickly as we can. So I'll progress to the next slide. And one of the other key aspects which I think we really want to share and make sure that it's a forward thinking for when you're considering your own special interest group, a key aspect of ours is really that encouragement and support of the next generation, so the early and mid-career researchers, and especially if they're clinicians and they don't really do much in terms of discovery science, pairing them up with some really amazing early career, mid-career researcher scientists, so that, again, they can grow and develop together and think about things even differently to, say, how Amanda and I might think about things now. And we think that's building the workforce of the future, cultivating incredible next generation of leaders, but also bringing in other niche specialties. So really involving cardiovascular experts as well as maternal health research. We think this will be part of the key to the solutions, as we've heard is urgently needed, that innovation for next diagnostics and next treatments. And also, this allows capacity and sustainability for the APN going forward. Amanda and I initially wanted to set this up as a special interest group, but we really now are looking for, and we've found who we think will chair, that they'll become the new chairs of APN going forward. And again, really thinking about that early mid-career pathway and who can we bring along to ensure that we're strengthening the research ecosystem and the future. Another key aspect is consumer voice or patient voice, which is embedded within our in the APN. And this is critical. I'm sure you're probably aware that lived experience expertise will be most important for us, particularly when we're thinking about barriers to diagnosis, treatment, and also follow-up care. improved trial design and uptake is also another aspect of why we want the consumers involved. And Amanda alluded to a little bit earlier that we had put a pilot program of research together, and very excitingly in 2023 we were awarded almost $1.5 million to actually to try and look at cohorts and risk stratify future cardiovascular disease in the future. So we've got funding. So what we're trying to do now is with the APN show them how that they might work together, other groups, and try and advance, rather than working alone in silos, how can we bring multiple members of the APN network together and actually think about those grants and trials going forward, working very, very closely. And finally, really that stronger translational and advocacy aspect that is really essential to driving preeclampsia treatments, care, as well as diagnostics forward. And so what we did last year, we'd been working on this for quite some time to make sure it was the right thing, but both myself and Amanda submitted a proposal to SOMANS to seek endorsement to formally endorse APN to sit within the Society of Obstetric Medicine Australia New Zealand. And this was for many reasons, but key to that was really enhancing participation of new interested members. We have a great group, but we also know that there could be some people missing, and if they belong to at least the larger SOMANS collective, but they're deeply passionate about hypertension or preeclampsia, then hopefully they'll join this group once it's formally established. And that was endorsed late last year by SOMANS Council. And so now we're in the final stages of designing our governance structure and appointing our 2 new chairs, which again, stressing that we'll have a clinician and a scientist to co-lead this going forward. Our website will be launched before our next SOMANS meeting in October this year. So people will be able to opt in to take a look at next stages, but we'll use that as a media to update at the community on what we're up to. And again, as I mentioned, really identify if that hopefully once the website's up, we'll have interested parties who want to join us. We'll be able to do that through the website and QR codes. So I'm going to leave it there now and hand over to Renuka.
Thank you, Ned. I'm just going to share my slides from my end, if that's all right. Oh, can you see my slides there? Excellent. So I would just like to begin by echoing Amanda and Natalie's congratulatory message to the team in putting together this special interest group. Remarkably a great effort and well done on putting this together. And thank you for having us join your meeting today. So in a sense, you've heard the wonderful work that Amanda and Natalie have done in putting together the APN for Australia. And I'm just going to add to kind of illustrate how the SOMANS and APN partnership has really helped remarkably, or has worked remarkably well in putting together our latest SOMANS guidelines. So in terms of just, going to see how the clinical research and the scientific research side of things translates into clinical evidence-based practice through the development of guidelines. So as some of you may be aware, the SOMANS hypertension in pregnancy guidelines was launched last year. And this was done to the specifications of NHMRC, which is the National Health Research and Medical Council of Australia. And in developing an NHMRC's standard guideline, the requirement is that we do have a robust methodology in developing our recommendation. And so this has to be an evidence-based recommendation through a prescribed methodology. But importantly, it does require an MDT panel of expertise and stakeholders. And this involves clinicians, which were made out of obstetricians, physicians, MFM physicians, critical care physicians, both who come from metropolitan and rural settings, but also the inclusion of midwives, scientists, pharmacists, and as Natalie emphasized, the importance of patient representatives. And in Australia and New Zealand, that also extends to First Nation women representatives. Now, this is certainly a big group to put together. And in our guidelines, we had a panel of 23 members, most of whom are actually APN members. And this essentially highlights the key role that an organization like APN plays in bridging, or rather creating a hub for networking. So this really demonstrates how APN and societies like APN helps like-minded clinicians come together in working on an important work like guidelines and also research in moving all the work that we do forward in helping women who are at risk of preeclampsia and suffer from preeclampsia have better outcomes. So in this instance, APN most certainly helped us connect with key stakeholders in forming our group for guideline development. APN also played an important role in assisting with the public consultation and review of our guideline. But as Natalie and Amanda alluded to previously, APAC also has a bit of a sister network, which is APAC, which is Australia Action on Preeclampsia. And this is a remarkably successful consumer representative group that's pretty big in Australia. And they played a pivotal role also in the public consultation period and also promoting the guidelines to women and also clinicians who care for women. So in a nutshell, I just basically wanted to emphasize how an amazing group like APN certainly helps connect all of us together in Australia and help like-minded clinicians come together in achieving our common goal, which is improving outcome for our high-risk women. So with that, I'll thank you for having us today.
I thank everyone at the APN and SOMANS for this introduction, and definitely the APN session at the Joint World Congress in October 2024 was highly inspirational to get us at SMFMI to set up our very own SIG with HDPPE. We also thank the Almighty and our teachers for this new venture. We seek their blessing. If anyone among the delegates is interested in working with the SIG, as Sir and Dr. Revati mentioned, you can avail to become co-members of SMFMI and work in the SIG as conveners or contributors and collaborate from your own region. Apart from the HDPPE SIG, which got launched today, the upcoming SIGs will be on labor and birth, preterm birth suraksha, and nutrition and pregnancy and lactation. We welcome collaborators from across the globe. Thank you. With this, we move on to the clinical panel discussion, and I request Dr. Prakash Mehta, sir, to take over the stage for the panel discussion as moderator. And I invite all our esteemed panelists to be on call and discuss about the placental dysfunctions and its implication on preeclampsia. First, I'll introduce our moderator, our president, our very own Dr. Prakash Mehta, sir. He's a chief in Department of Metal Fetal Medicine, Bhagwan Mahavir Jain Hospital, Bengaluru, president of SMFMI, Indian co-chair for Preeclampsia Education of the Nation, India, organizing chairperson of the Aishap World Congress 2023, so has contributed numerous articles in various journals, contributed chapters on maternal fetal medicine and many books, and delivered oration in field of maternal fetal medicine at various places. Thank you very much, sir. Our esteemed panelists include Professor Renuka Shanmugalingam. Madam has collaborated with us earlier. She's made remarkable contributions to the field of renal obstetrics. She's a nephrologist and obstetric medicine physician at Liverpool Hospital, Sydney, Australia. She's an executive council member and education committee chair at SOMANS and was lead of SOMANS's hypertension pregnancy guidelines in 2023. Her areas of interest include hypertensive disorders of pregnancy, aspirin, and post-preeclampsia care. Welcome, Doctor. Well, it's a great privilege to welcome Professor Amanda Henry, who is Program Head for Women's Health at the George Institute for Global Health, Australia. She's the Professor, Discipline of Women's Health, UNSW Medicine, and Health and Obstetrician at St. George Public Hospital, Sydney, Medical Advisor for the Australian Action on Preeclampsia. Professor has co-founded the clinician-scientist-led APN with Professor Natalie Hennin through extensive local and global collaborations. Welcome, Professor. I now welcome Professor Natalie Hennin, Head Therapeutics Discovery and Vascular Function Pregnancy Laboratory, University of Melbourne. She's the Director of SOMANS, and she has co-founded the Clinician Scientist-led APN with Professor Amanda Henry. Welcome, Professor. I welcome Dr. Anu Joseph, Consultant and Medical Director, Trinity Healthcare Clinic, Electronic City, Bengaluru, member of ICOG, SMFMI, and contributor to the textbook Preeclampsia and Enigma Unraveled, A Global Perspective, and PENI, an online certification course in preeclampsia. She's presented scientific papers in reputable journals, conducted fellowship research on first-trimester serum markers for predicting adverse pregnancy outcomes. I welcome everyone for the panel. So,
Okay, welcome to this panel on placental dysfunction and preeclampsia. We have a small change in the panelists. Dr. Uma Ram has fallen sick. She is hardly able to speak. Actually, she sent me a recording of her voice, which I could barely make out what she has told. So we requested instead Professor Shashwati Sanyal, who just happened to be today with us. So, Madam Shashwati, would you please join us for today's program?
Yes, thank you, Dr. Prakash, for including me.
Professor Shashwati is always available to us whenever we run into trouble like this. Most of Chennai is going through a very bad viral upper respiratory tract infection. And unfortunately, Professor Umaram has caught it and she's not being here with us. So, Professor Shashwati, I'm sure your words of wisdom will be a great boon to today's panels. Now, we all know that the placenta is vital in providing oxygen and nutrients to the developing fetus and also to remove the waste products. Now, what happens in placental dysfunction is that the placenta is unable to supply sufficient nutrients and oxygen to the fetus, resulting in adverse outcome. I mean, it's a very simple principle. We all know that. But what is very interesting is that James Young in 1914 has already written that one can be left in no doubt whatever the disease in the placenta, it is secondary to the deprivation of the maternal blood supply. So a really philosophical statement made long back, even before any kind of technology was available. So with this, we begin with the root cause. I think I will get in Dr. Shashwati first. How does placental dysfunction occur and what's happening at the level of the placenta?
Thank you, Dr. Prakash, for including me in an extempore panel. And I'm absolutely not prepared. But I hope all of us know the basic thing is placental dysfunction is the secondary invasion. And the angiogenic factor and the inflammatory cytokines, these are the important things which helps in the secondary invasion, by which you develop a low resistance blood supply where the exchange of the gases from the fetal side and the maternal side occurs. And by that, fetus gets enough of oxygenation as well as other nutrients for the growth. So the basic problem, what we think is that for the early onset, especially because this is a placental disease, early onset preeclampsia, is when the placental dysfunction occurs because of the secondary invasion of the basal arteries of the spiral, the basal part of the spiral arteries. That's what we understood till now. And the second phase, we have this because of this, in reaction to the placental, whatever the debris goes to the maternal because of the death of the placenta goes to the maternal blood, and thereby mother also produces some reactive something or some disturbances, some kind of changes in the molecular level, and which can also cause this changes which results in the hypertension or other effects of the placental dysfunction, which may cause a preterm labor, especially the fetal growth restrictions, and even PPROM is also then HELP syndrome and all other diseases that is responsible for the bad fetal-maternal outcome.
Absolutely, Professor. Very well put in. I'll just stop share for a minute and rejoin because there is some issue with the sharing part. I'll just... Okay, so basically the placental insufficiency starts from the time of implantation and goes on further. And, we have various prophylactic windows in the early pregnancy development and the therapeutic window later on. So that is why it's very important to understand the placental dysfunction and how does it come. Next question goes to Dr. Anu. Are there any risk factors that are pointers to placental dysfunction?
Yes, sir. So we have had multiple risk factors that is pointed towards placental dysfunction. Now, the problem is that to put one in front of the other and say this is high risk, low risk, or intermediate risk is extremely difficult because there are multiple factors at play. We can divide it into few things which are personal, that is the weight, the age, and things like that, and few things which are nutritional, like the amount of anemia that they have, as you've put up, amount of low vitamin C in their food, excess of tea, coffee intakes, and things like that. But more than this, I think just like our Gestosis score, which talks about preeclampsia risk, placental dysfunction risk also comes with the age, with the BMI, with the parity, the number of previous pregnancies which has gone in with problems that would have told about placental dysfunction, etc.
Sure. Okay. Just a minute. There is some. Give me 1 more minute, please. I have to share again. Placental dysfunction is exactly like this. You have confusion all the time. So I'll just reshare once more.
While Sir is getting that done, may I ask all the three from Australia professors, do you really use only the prior risk as a factor for putting women as high risk, low risk, or intermediate risk?
So no, obviously prior history is a strong risk factor, but and maybe Renuka wants to speak to it with the SOMAT's guidelines, but we've got a table of sort of both the highest risk and then moderate risk factors, but we also acknowledge that for preterm preeclampsia particularly, that if you have access to the full screening model, including the first trimester ultrasound, biomarkers, uterine artery Dopplers, then that will give a better estimate in terms of preterm preeclampsia risk. Renuka, I'm not sure if you have anything to add.
Yeah, thanks, Amanda. I might just add a little bit to that. Thank you for that question, Anu. So in a sense, exactly as what Amanda has just mentioned. So I think if we were to look at just clinical risk factors, both the SOMAN's guidelines, in keeping with the current international guidelines, such as the ACOG and also the NICE guidelines, stipulates that if women have one of the 6 major risk factors, which is underlying chronic disease, chronic hypertension, prior preeclampsia, autoimmune condition, or type 2 diabetes, or type 1 even for that matter, they would by default be categorized as having high risk for developing preeclampsia. Now, there's a separate column that lists about 9 different moderate risk factors. So if they do not have one of the major risk factors, they should have 2 of those 9 listed moderate risk factors to be deemed as being high risk. But as Amanda alluded to this before, classifying women just based on clinical risk factors only appears to pick up about 20 to 30% of women who are at risk of developing early onset preeclampsia. But the use of the combined first trimester screening, which I think Professor Kingdom mentioned about before and Amanda Henry was alluding to before, where you use the combined uterine artery Dopplers, biomarkers like PLGF, PEPA, and also maternal MAP, so mean arterial blood pressure in combination, improves the pickup rate to about 96% in identifying women who are at risk of developing preeclampsia. So most certainly a far more superior screening tool. The issue, however, is access. Where it can't be accessed, we revert back to clinical risk factors.
So absolutely, we need to keep the clinical factors uppermost in our mind and then try to search for other factors which could lead towards a placental dysfunction. The next question goes to Professor Henry. When we discuss placental dysfunction, great obstetric syndromes must be talked about. Could you just elaborate on what are great obstetric syndromes?
Yes, thank you. So when we're saying great obstetric syndromes, we're talking about these conditions that are arising from failure of usual placentation. So the usual process is physiologically is that the spiral arteries, remodel, and the uterine circulation changes from the non-pregnant, high resistance, low volume of flow to low resistance, high volume of flow as the placenta develops in the first half of pregnancy to sustain the fetal growth. And so conditions that arise, as we're seeing on the slide here, from that placental failure, preeclampsia, and then fetal is a big one. Fetal growth restriction is also a big one. Of course, they may coexist, but it is, as we all know, possible to have fetal growth restriction without preeclampsia. And then various preterm labour PPROM syndromes arising from sort of placental inflammation, ischemia, placental abruption, again, which can coexist with either preeclampsia or fetal growth restriction, and of course, at the worst end, pregnancy loss.
Absolutely. So the great obstetrical syndromes are directly a result of placental dysfunction. It could be abnormal placentation, or it could be poor placental flow, a vascular pathology, a placental inflammation, and so on. Next question to Professor Hannan. How does placental dysfunction cause placental abruption? Because placental abruption is one of the very common obstetrical syndrome. So how does it cause placental abruption?
Yeah, so thanks for the question. And I think if we think about going back to when implantation actually is occurring, and we're having that reduced invasion by the maternal of the maternal spiral arteries by the developing placenta, it's not establishing a very strong root system, if you can imagine. And so what ends up happening is those vessels and the decidua are not deeply connected to the placenta. So we want that to be very strong and anchored really well, so it invades quite deeply. In preeclampsia, for some reason, this is not occurring properly or deep enough or connected enough. And so then when we run into trouble later on in pregnancy, the placenta can be removed very easily and dislodged from, so that connection is very weak between the placenta and the maternal uterine decidua. And so you can see on the slides here exactly to why this is occurring. And then that you then in the clinic, you will see that as quite a very dangerous emergency outcome that needs to be sorted before the placenta essentially completely dislodges, and the maternal system is just expelling that blood, and the baby is no longer connected to the placenta but still in utero. So that baby then needs to be removed very quickly. And so this is why we see a lot of placental abruption with where the placenta has not set up properly.
Absolutely. So basically, there is some kind of a poor trophoblastic invasion initially, and later on, ischemia sets in, and that results in a train of events that ultimately results in abruption.
Absolutely, yes.
Now, next question back to Professor Hannan. There is a history of threatened abortion in this patient. Does it predispose to placental dysfunction?
So it's very complex, and I'll say sometimes yes and other times no. And so what we know, and again, it comes back to if we're thinking about early onset preeclampsia and possibly late onset preeclampsia might have a different etiology. But if we think about a patient who in a previous pregnancy who hasn't set up a proper placenta, they're more likely in their next pregnancy to also not set up that placenta in a deep way. We would like the placenta to quite deeply invade the maternal decidua endometrium. And so you can think of it that it does predispose someone to placental dysfunction if they have a history of prior pregnancy loss or abortion through the abnormal setting up. And so we know that patients who have had a history of that, we need to keep a very careful eye on them in subsequent pregnancies. And there's definitely different monitoring and different, now we would probably, Amanda and Renuka would probably look after these patients differently and thinking what prophylactic therapies might be useful, such as aspirin, as alluded to on the slide here. And so I think yes and no is probably the most accurate answer, but it is quite complex, and we have to weigh in also different fathers as well, potentially if it's new parents in that next pregnancy as well.
Yeah, thank you. I think the lesson as clinicians for us to learn is that if there is a history of threatened abortion, especially if there is a retrochorionic hematoma, make
Yes.
sure that this patient is followed up and closely monitored for any kind of placental dysfunction as pregnancy advances.
Yes, absolutely.
Okay, next question to Anu Joseph. What ultrasound and Doppler findings can be present when there is a placental dysfunction? I'm sure we have covered part of this in Professor Kingdom's lecture, but could you just summarize the whole thing and tell us?
So when there is a placental dysfunction, we have to divide it into what we can see in the first, second, and third trimester. So in the first and early half of the second trimester, they're all like our 16 weeks and prior, the predictive changes that would be there. And in the later second half and the third trimester of pregnancy, there would be the treatable problems or things that would be of obstetric importance in terms of labor and delivery. In the first trimester, we would look at things like uterine artery Dopplers, which would go for a high PI, and that would tell us that there is a possibility of, in terms of screening, there is a possibility that this person might end up in a placental dysfunction. In the second trimester, the Dopplers would again tell us about the continuing problems with the uterine artery Doppler. And once we reach the third trimester, it would help us in understanding how bad to stage the various FGRs, fetal growth restrictions. On the other hand, we can also look at certain scan findings which are not directly Dopplers, but looking at the baby as a whole in terms of fetal growth restriction. We can also look at the placenta as a whole, small placentas, big placentas, thick placentas, echogenic placentas, the placental rim, the calcifications of the placenta, like Professor was talking about, thrombotic placentas, placental lakes. So a wide variety of things in terms of placenta in itself, to talk about whether they are going in for a dysfunction or not. Again, like Sir said at that point of time, that we don't have very many classification or grading to say, okay, this placenta is going to be bad or this is going to be good. The other Doppler findings, which we use once the fetal growth restriction really gets into being a little bad, staging up, we use the middle cerebral artery Doppler to calculate the CPR ratios, cerebroplacental ratio, and also on late stages of fetal growth restriction, the ductus venosus Doppler, and extremely rarely the aortic isthmus Dopplers to talk about when to deliver a baby, to tell about if the baby is going to come out acidotic or not, and probably also the route of delivery. Do we have time for induction and vaginal birth, or do we have to do an emergency section for this baby? So that's about it.
I just want to add something.
Sure.
Yeah, ophthalmic artery Doppler has got some role.
Yes.
Yeah,
New,
ophthalmic artery Doppler.
one of the newer predictive models. The only issue with it is it's still not into any of the guidelines that we have had. So I didn't want to start with that. Ophthalmic Dopplers in the second trimester especially has come out as a good add-on mechanism. First trimester is still under study. But yes, a very good, effective, and probably not costly. I mean, it can be done at the same sitting as we are doing the anomaly scan as well as the NT scan. We can, of course, start using it, publish papers, and probably that comes into the guidelines soon.
Yeah, thank you, Anu. There's one definite take-home message is that we have been ignoring the sonography of placenta quite a bit, I suppose, because most of the reports that you see would just mention that, okay, placenta is located at the fundus or anterior wall or posterior wall, and that's it, nothing more than about placenta in the reports. I think the size, the morphology, the venous lakes, the intervenous spaces, all this needs to be a little more elaborated, then we could pick up our placental dysfunctions in a much better way.
So also the cord implantation site, if it's velamentous, if it's marginal, all that also
Absolutely.
plays a role in telling about dysfunctions.
Absolutely. I think from even after this today's session, I hope some of us will go back and make sure that the placenta is studied in a much better way. Professor Henry, next question to you. Is there a correlation between placental calcification and preeclampsia?
I'm interested to see what you have on the answer. I went and had a little look at what's the latest here. So the answer is yes, but not necessarily in a clinically useful way. As it says on the slide, physiologic calcification is almost universal in the later part of pregnancy. And for many years we kind of had a great, because it was known that noticed that there were some associations with things like preeclampsia, late stillbirth with a really calcified placenta. There was, gradings of Granum 1, 2, and 3 in terms of how mature the placenta looked in terms of the calcifications. But then it's quite common to have a very mature looking placenta with calcifications just in normal late pregnancy. And so that's why I say clinically it's not necessarily very useful. And you have to be careful that you don't just increase intervention by taking note of the calcifications rather than improving the outcome. However, I would have to say that in the grand scheme of things, you should use it as part of your overall thinking. So when you're having, a look clinically at this woman, is the blood pressure normal? Is it high normal? What's the size of the baby? What else is going on in her past history? How does the placenta look overall? If I have a few things that are worrying me, I add calcification into my overall estimate of things. Yeah.
True, I agree with you. Even when we were postgraduates, we were asked to read a lot about Granum's classification, that 1, 2, 3 and all that. And there used to be questions asked about that in the exam, and then it went away. But now we still again realize that calcification may be an important factor, because the amount of calcification brings down the amount of active placental tissue, which could transfer the nutrients across. So maybe that could be one of the reasons. Because before 32 weeks, if we see any calcification, I think we need to be a little more careful about this patient.
Yeah, absolutely.
Okay, next question I think I'll put it to Professor Saraswati. Can a small placenta be the reason for placental dysfunction?
I think it's possible, because usually we have seen there's a ratio of the baby weight and the placenta. So if the placenta is small, we have seen in most of the cases, the small placenta is associated with fetal growth restriction. And this is also, I think, the weight of the baby and the weight of the placenta, there is association. So that is why I think the small placenta can be a cause of placental dysfunction, because the effects are seen in the clinical scenario.
Absolutely. For those who are used to the Indian food, whenever you see a placenta like what we call as rava idli, it's like a small blob, thick blob. So if a placenta looks like rava idli, then you have to be really worried about that placenta. Okay, the next question. We just quickly go through a case. A 47-year-old elderly primary gravida. It was an IVF ET donor egg conception at 24 weeks. Early onset preeclampsia, type 2 diabetes, blood pressure elevated right from 22 weeks onwards. She was already on tablet labetalol. It didn't get controlled. Then she was added nifedipine, and she was on insulin because of her diabetes. By scan at 24 weeks showed a reduced fetal growth. It was only 1 centile with an absent end-diastolic flow at 24 weeks. However, the fetal movements were normal as per the patient. And on examination, in my center, we do a lot of early NSTs. So the NST on this patient proved to be reactive. She was, of course, given magnesium sulfate for neuroprotection, given steroids in case I need to deliver her early. And from 26 onwards, from 24, I could take her up to 26. But after that, her hematology and biochemistry started worsening a little bit. She gained a weight of 7.1 kg in 10 days, increased abdominal girth, and ascites started coming in, and uncontrolled blood pressure came in spite of the treatment. So ultimately, I had to decide on a cesarean section, and a female baby of 510 grams with reasonably good Apgas was extracted. And the placenta was only 130 grams with a lot of calcifications. Ultimately, the baby did well in NICU. The mother did well, and I think I got away with a real problem rather easily, thanks to God's grace. So this was an ART pregnancy. Again, I think, Professor Shaswati, back to you. Is ART associated with placental dysfunction?
I think in many cases, it's my experience, there is some relationship with ART and placental dysfunctions, because a very good, one of the major risk factor for hypertension in pregnancy is ART. And it gives, even in gestosys score, ART pregnancy is associated with this. And in this patient, she also has a diabetes, this particular patient. So she's a very, very high risk of placental dysfunction. So, and most of the cases when you do ART, a good number of them, they also have associated other risk factors for development of, say, BMI or maybe polycystic ovarian disease. So many things who can develop diabetes mellitus later on. And of course, the advanced maternal age. So they have all these thing together in ART patients. So all these gives rise to, and even the sometimes given multiple pregnancies, twin, triplet, all these pregnancies, which are associated with ART. So these are the factors, most probably they are associated with placental dysfunction and cause of problems with growth.
So once we have an ART pregnancy, we need to be monitoring those pregnancies very, very carefully.
Absolutely.
Next question to Professor Hannan. Kanye West had a surrogate baby. Do surrogates have increased placental dysfunction?
Yes, good question. And surrogates do often have increased risk of placental dysfunction. And this comes back to a lot to do with that maternal fetal interface, where the decidua is made up of maternal immune cells, and you've got infiltrating foreign trophoblasts from the father, and in this case you've also got whoever was the egg, so the donor egg. So you've got 3 different sets of genetic coming in, and the immune system will not like this very much. And the immune cells that sit within that maternal fetal interface, that environment, they will see this as a threat, and they will actually, in some situations, switch on host defense mechanisms. So if we were to be sick with a foreign pathogen coming into us, our immune system would recognize that. And it's very similar in the maternal immune system, sitting right at the maternal fetal interface. And so we just increase the risk again. So as we just heard, ART itself, so assisted reproductive technologies, already have elements that will increase risk. They will be there with the surrogate, and then now you're adding an extra factor of these different genetic causes. So the immune system is really critical, particularly in that first 6 to 12 weeks of placentation, and can actually at that point set up dysfunction. The other thing to think about as well is the maternal cardiovascular system also will be seeing some of these placental cells as it floats around the body, and the maternal immune system will be there. So the surrogate's immune system will be sensing again these different genetic factors coming from the foreign placenta and the foreign fetus, and that can also sensitize to endothelial dysfunction, which is that second phase of preeclampsia.
Absolutely. So possibly the genetic differences do play a role in causing more issues in the surrogate mother. As far as my practice is concerned, whenever a surrogate is referred to me, I definitely have an adrenaline rush, because they are really difficult to handle.
Yeah. And complex.
Yes. The next question, again back to Professor Hannan. Does epigenetics influence dysfunction? And for the uninitiated, could you please describe what is epigenetics?
Yeah, so epigenetics absolutely plays a crucial role in placental function itself, so establishment of the placenta and then its maintenance throughout pregnancy. And its disruptions to these epigenetic processes can drive placental dysfunction. And so what is epigenetics, and thinking about placental epigenetics, is the DNA methylation. So within the placental tissue, we have methylation of DNA. And what happens in this situation, we have histone modifications. But in a more simpler way to think about it, the epigenetics are the genetics of the individual, but they have special marks or environmental changes that will affect the genes themselves. And you've got this on the slide as well, but this can be thought of as the imprinting disorders. So certain genes in individuals, in people, are expressed on one allele, and then you'll have different ones coming in from the parents, so the maternal and the paternal. And again, when we're talking about assisted reproductive technologies, there could be also influences of hormones and other things on those genetic as well. So the genes again are marked when they sense environmental changes, if you will. So absolutely, you can imagine that when you've got ART involved here with all the different hormones to stimulate for egg production, and then to thicken the decidual lining for implantation and various other things. Not to mention, usually we are seeing these patients are in advanced maternal age, and they'll have had more time, therefore, for their DNA to be susceptible to these marks or these methylation points within the DNA, which again then will drive different ways those genes respond in the setting to make that placenta. So yeah, absolutely. Epigenetics are probably one of the key things that we haven't really explored enough that is actually driving first placental dysfunction. And so I think this is an area that we should be focusing on a lot more in the future.
Absolutely. Epigenetics is taking one of the upper hand now for causes for placental dysfunction. And unlike a mutation where there is a DNA alteration resulting in gene dysfunction, in epigenetics, it is the environment that causes some changes without altering the DNA sequence of the gene.
That's right.
And one of the common reasons could be methylation, where a methyl group is added to the DNA, and this changes the entire function. Now, another very important point with ART pregnancy is that we have not concentrated very much on the embryo culture media. And possibly we don't know whether some kind of epigenetics is coming in because of those media that are being used. I think it calls in for a lot more research so that we understand this problem in a better way.
Absolutely. And there are some really exciting studies coming from animal studies in different, so cattle have now shown that if the culture media is different, we do see these epigenetic modifications, and we have increased incidences of diseases such as Beckwith-Williams syndrome with ART, which we think it is due to this DNA methylation. So I think we do need to take a lot more care in thinking about what our embryo culture media is made of, and does it replicate what that embryo would see in that peri-implantation phase? And if not, that's another area I think that we really need to think about, could have a preventative approach to the increased incidence of preeclampsia with ART.
Sure, we are going to definitely hear more and more about epigenetics in future. Oh, the next question again goes to you. This patient had diabetes. Does it influence dysfunction? Does diabetes have any action or any effect on the dysfunction?
Yeah, so this is really important to think, if the patient has gone in, which this patient did, the patient already had diabetes going into pregnancy, so pre-existing. And if that diabetes isn't well controlled, that diabetic environment, particularly hypoglycemia, can impair placental development, implantation, and its function. And this potentially leads to complications for the mum and the fetus going forward. But absolutely, it will impact how the placenta first establishes and then how it's maintained. And you can see on the slide here that can result in things like altered blood flow through the placenta. So that perfusion might be weakened because the vessels didn't set up properly in the first instance. It can absolutely affect how the placenta itself makes its own hormones. HCG is a key and important one, as well as inflammation. So the placenta, when it's inflamed, will then release more inflammatory mediators into the circulation, and it has that then waterfall effect. It just keeps affecting the next stage. And we know that the placenta vascular changes are different in women with either gestational diabetes or type 2 diabetes. And we think that there's a strong link here to think about the vascular and endothelial dysfunction in it could be in a diabetic patient, but also in a patient with hypertension in pregnancy or preeclampsia. So I think we need to really think about the patients with diabetes, whether it's type 1, type 2, or those patients that get diabetes during pregnancy, really thinking about that endothelial dysfunction and can we keep the disease, the diabetes controlled so that we don't have impact on the maternal cardiovascular system.
Absolutely. I think the very important lesson is that every diabetic pregnancy needs to be monitored very carefully. And even if it is GDM with just a mild derangement of sugar, still it could have a placental dysfunction and we need to watch for it. Thank you for bringing out that point very clearly.
Thank you.
Next question to Professor Henry. Does the age of the couple play a placental dysfunction?
So the short answer is yes. And then the slightly longer answer. So both paternal and maternal age matters. In terms of maternal age, extremes of age matter. So it's not good to be very young. And that's probably in terms of kind of immunological factors, underpreparedness of the body for a first pregnancy at a very young age. And then at older age, so greater than 35, but especially greater than 40, more uteroplacental dysfunction. And look, some of this is going to be more about as mum is aging, she's bringing more risk factors in, so more likely to be higher BMI, more likely to already have a chronic disease of some kind, and then, yeah, as shown on the slide, that results in various placental dysfunctions. There is, and it's important to note, it is a bit hard to tease out some of these parental type associations because of the various confounding factors, things like having IVF, for example. But there's actually been a really recent systematic review published just in the last few weeks looking at paternal age and various pregnancy complications, including hypertensive disorders, and it does suggest that the combined evidence suggests that older paternal age also matters, although less strongly than maternal age.
Absolutely. One of the interesting findings was that we know that the elderly women have lower AMH, and the lower AMH was found to be associated with the lower maternal serum PAP-A and a high PLGF split ratio. So that's from where the placental dysfunction may be starting. Okay, the next question I think goes to Dr. Anu. How does placental dysfunction cause preeclampsia? I mean, we have already covered it, but just a quick recapitulation.
So placental dysfunction is the root cause of preeclampsia. The whole point is the blood flow to the mother and the baby gets reduced, and that causes placental ischemia. And once that happens, there are lots of placental factors. There are lots of free radicals that gets released, and that would end up in making sure that there is hypertension at the end of the day. Now, unless we think of placental issues as a problem, we will never find out a solution to the problem called preeclampsia. So that one-on-one care is something, and one-on-one studies are something that we would want to see again in the future, so that we would tackle the problem of preeclampsia better.
Thank you, Anu. So that's how the placental ischemia and further action changes. Dr. Renuka, I know you are there, but in any good lunch, the best part is the dessert. So I'm keeping you for the dessert. Okay. The next question back to Anu again. What are the earliest signs of placental dysfunction that the clinician should be aware of?
So once again, just like the previous question on ultrasound, we should be aware of the earliest signs from the first trimester. If we are doing a good history taking, that itself would tell us about a possibility of a placental dysfunction coming in. In the first trimester, our first trimester screening, if done well, including uterine artery Dopplers, Pape values, and if at all possible PLGF added on to it, it would tell us a lot about the future add-on of placental dysfunction in the later on half of pregnancy. So that's almost about our first trimester. In the second trimester is again mostly about the mother. If the mother starts showing up edema, if the mother starts increasing the weight too fast, if we start seeing any sort of fetal growth restriction in the baby and still the BP has not shot up, or the BP has started racing up from the baseline, and it's not just a 140/90 or a 150/100 that we are looking at. If the BP has started going up, I remember you telling us when we were doing our fellowship that a mother who has not had a dip in her BP in second trimester probably will go in for a preeclampsia in the third trimester. So simple things which if we don't see, we will be taken for a ride in the third trimester. So all these things, clinical, history-wise, as well as examination-wise and testing-wise, would tell us, yes, there is an early dysfunction, a placental dysfunction coming in. And the good part about the early dysfunction, the early signs of dysfunction, especially if it happens before 16 weeks, and why that is important is because that is a time we can give this magic pill of aspirin and make sure that at least a good number of women who are destined to be severely preeclamptic may require a very preterm delivery, may require to have delivery of an extremely fetal growth restricted baby, an acidotic baby. There can be given a very cost-effective magic pill called aspirin, and we can shift the tide towards a way better mother, a way better baby, and an even better obstetrician who's giving care to them. So I think these early signs of dysfunction has to be made loud and clear to all practicing obstetricians and through our programs to even to parents and would-be parents and future parents to know the early signs and act accordingly.
Yeah, thank you, Anu. That was a very nice and precise answer. The next question goes to Dr. Henry again. Professor Henry, how does placental dysfunction differ between early and late onset PE? Is the placental dysfunction different in these two disorders or is it the same?
So overall, yes, it's different. Having said that, there is overlap in the pathological features. So it's not that we can neatly and totally separate it into an early onset and a late onset sort of basket. But the early onset is much more about, I guess, everything that we've been talking about and everything Professor Kingdom was showing, which is that failure of placentation sort of early on, and with much higher associations both with signs on ultrasound like a thickened placenta, early premature calcifications, very small placenta after the baby's born, and then growth restricted babies. Whereas late onset, it's more like the a little bit of premature aging and we're just running out of puff, and mum's vascular factors and vascular risks that mum is bringing into the pregnancy seem to be a much higher player in the later onset. And so consequently, mum can be just as sick with late onset preeclampsia versus early onset preeclampsia, but fetally, we often have normal fetal growth, or if there's growth restriction, it's generally much milder. And yeah, as it says on the slide, the early onset primarily that placenta driven, later onset more influenced by the maternal systemic factors. So yeah, different differences, but it's not complete, and there's definitely overlap.
Yeah, so basically the two diseases appear to be slightly different, and the early onset preeclampsia is mainly placental driven, while the late onset preeclampsia has maternal systemic factors interacting to make it a little more pathogenic. Dr. Shashwati, next question to you. what innovations can help bridge gaps in the low resource setting? We always say that, okay, this is a low resource setting, we don't have this, we don't have that, we don't have any further investigation cost, everything comes in. So what kind of innovations you think can help in bridge these gaps?
I think, as you say, that we have to find whether there is placental dysfunction in this particular patients or not. So you have already told some of the predictors. Now, some of the predictors can be combined together in low resource settings. Say, for example, we always do the dual marker, or we do uterine artery Doppler, we look for mean arterial pressure. So all these things together, which is in low, PLGF is an expensive thing. So that is not possible for do. But even doing the simple combined, that is look for dual marker, that is PAPE level, do for uterine artery Doppler, and the other general score of the mother having the previous factors which is responsible. So simple gestosis score or simple doing this minimal investigations, that is the dual marker, uterine artery Doppler and mean arterial pressure. I think we can pick up at least a good number of patients, if not 75. I know because we have done a study with a multiple predictors, which includes PLGF in the first trimester, a MAP, and your PAPE level. All these together, we have found out that 99% of the disease can be predicted for preeclampsia. We have a study which has been published in Foxy Journal. So, but this is not possible in all patients, PLGF in the periphery. But mean arterial pressure, uterine artery Doppler, and if the dual marker is doing in our medical college, dual marker is done routinely for all patients. So those patients, this can be done easily for low resource setting. At least the uterine artery Doppler and mean arterial pressure. These two also can pick up some of the cases.
Absolutely. I think once the point of care tests become very common, our pickup rates are definitely going to go higher. And let me announce to this audience that from the Society for Maternal Fetal Medicine, we are starting a research project on PLGF as a point of care test. It will be done bedside, and we are hoping that the cost would stay somewhere around 1,500 to 2,000 rupees once a mass manufacture starts, which is really not a very big sum, because even for a regular scan, you pay 2,000 rupees. So a PLGF point of care test, if some such thing really works very well, and I'm sure from the SMFMI, when we do our research, we will get an answer to it. We should be able to predict and able to innovate the care for our women in a much better way. Next question to talk. Yes, anybody?
Sir, as we talk about gestosis, I'd like to welcome Dr. Girija Wag, madam, here with us.
Hi. Hi,
Hi,
everybody.
Giri. We missed you all the
I
time.
know, but I was listening. I was, incidentally doing a preeclampsia, came in emergency prom.
Okay. All right. Now you get a tough question because you joined us late.
Okay.
What is syncytial trophoblast stress and how does it influence the outcome?
So basically,
because we know that placentation is more than spiral artery modeling.
Yeah. But then at the end of that, there's a syncytial trophoblast, which undergoes a hypoxic damage and a maldevelopment. So it's not a maldevelopment only secondary to the vascular malformation or malfunction. And that is the reason why there are a lot of noxious elements which get released into the blood in simple language. And this would really give rise to the problems that we are seeing, because many times we see that it would be because of malperfusion, malplacentation, and it is something a result of what has happened when the spiral artery remodeling didn't occur. And therefore, there will be excessive oxidative stress there, and all the cascade of preeclampsia, which manifests later, we come to see. But this particular stress can very well be identified by the early things that we are talking about at the time of maybe the 12-week scan or the 16-week scan. And that would give us an insight as to what would be our possibility of going ahead with it. This stress is a result of tissue destruction. And I don't know why one or two questions and discussion points I missed, but I feel some women, despite having this stress, would manifest the disease a little later, some will disease earlier. This can be because of their immunological clearance pathway, is what I feel. And this is the typical Feinberg's hypothesis, which I love always to remember, that there is something, these complexes get collected by that blood and get released. So syncytial trophoblast stress is basically a result of abnormal placental perfusion, which then manifests into a placental problem.
Yeah, absolutely. I think that the immunological basis is, along with the genetic basis, are the very two important
Yeah.
factors. Professor Natalie and Professor Henry, Dr. Girija is a great friend of mine. And she's very good in preeclampsia. And with the entire protocol for management of high-risk pregnant patients for all India at all India level, Girija Bagh and me were partners doing that entire protocol. So, welcome once again, Dr. Girija.
Thank you so much, Prakash. Thanks for being patient with me and my work.
We are all obstetricians, we understand.
Yeah, thank you.
Okay, with that, we go to the next case, which is the primary gravida at 27 plus weeks of gestation with DCDA twin, severe preeclampsia on labetalol and nifedipine, and one twin 26 plus weeks, another twin 24 plus 3 weeks. Ultimately, because of the problem, she had to be taken up for a cesarean section, and one female of 860 grams, and twin B was another female of 560 grams. Liquor was clear, adequate. Twin A had velamentous insertion, while twin B was a normal incision, and the total weight of the placenta was 560 grams. So we do know that the twins and placental dysfunction are interconnected. We have from the Greek mythology, the Cosmos and Damian, who had created a lot of problems in the world as per the Greek mythology. And of course, we know the twin towers, how they were attacked. So anything that is twin is going to have problem. And women with twin are 3 times more likely to develop preeclampsia and have an increased chance of abruption. So the next question, I think I'll get in Girija again. How does multiple pregnancy cause placental dysfunction?
Okay, so basically, one thing we have to remember that when there is a multiple pregnancy, there's also going to be a larger placenta, which ideally should happen. So if everything goes well, there has to be a big placenta because it has to support each baby separately. But having said that, this particular placenta, if that vascular remodeling and all these things, the genetic predisposition, immunological problems, all the priori risk factors, if they come into being, then this particular placenta is going to create a more whole lot of syncytial trophoblast stress, as we have been calling it, creating a lot of these malfunctioning tissue products because of apoptosis, and therefore is going to cause a more lot of load on the woman's system. Previously, when we were learning yet and we were not knowing about spiral arterial remodeling, we were thinking that it is because of the large placental tissue and maybe HCG hormone, which is the cause for the preeclampsia, which we used to find in context of twin pregnancies. But even in twin gestation, we still hold true. There's something called as an early onset preeclampsia and a late onset, definitely. But we will also see that presentation, which will be even before 20 weeks of gestation, where the woman may present with preeclampsia. Now, I'm not talking of chronic hypertension or gestational hypertension. I'm talking about preeclampsia, which means proteinuric hypertension. It may get into an HELLP syndrome. And all these possibilities, especially, have been seen in women having priori risks. Like they have some diseases, some autoimmune disorders, or some thrombophilias. But having said that, preeclampsia, twin gestation definitely is a risk. Now, many women come to us saying, I want to have 2 babies, madam, and it would be so nice and cute. But I tell them there's nothing cute about twins, as you told us about the twin towers and everything. And especially now, when we are seeing a lot of patients coming with ART, and they are typically multiple gestation or a twin gestation, we find that even if the twin pregnancy disappears for any reason, that there is a disappearing twin, still that risk exists that the patient will have preeclampsia, or if not preeclampsia, definitely gestational hypertension. So anything that has been multiple, anything that has been a vanishing twin, anything that has been one twin disappearing, twin along with a vesicular mole, it is a shaky antenna, and we have to be on guard and a close surveillance for these women.
Absolutely. Multiple pregnancies, multiple problems. And as you rightly pointed out, either there are two theories basically. One is increased immunological response and or genetic incompatibility theory. The other one is a placental mass hypothesis. We are not sure which of the two is really right, but maybe both are working together to cause an issue. Does the risk of preeclampsia differ because of chorionicity? If yes, why? Yes, Girija, back to you. As a special punishment, since you joined us late, you get an extra question.
I have a feeling, I am not sure about a very, very clear evidence to say this. But I have a feeling and an observation that usually MCDA twins are the culprits. Monochorionic twins definitely cause a more possibility of preeclampsia. I wonder why this happens. But this is my observation. I know there are small such studies which have said so. But if there's anything better evidence, I would like to listen to that. But whenever it's an MCDA twin and we are deciding to take them further, we really find that there is some challenge in the placentation that we see giving rise to preeclampsia. So it's not only about the babies going into problems, it's also the mother going into the problem. And another syndrome, which I think we are now understanding a little more, which was already said in the past, is the mirror syndrome. So the same kind of a thing which is happening to one of the twins can happen to the mother as well. And this would be more common in MCDA. And that's the reason why, Prakash, I always feel that gestosis is the right terminology because all kinds of inflammation comes into being here.
Absolutely. So, but there are a lot of articles, as you said. Some say that there is a difference between DC and MC. The others say there is no difference. Professor Henry, would you like to pass any comments regarding this?
So I think on the slide here you've got so potentially you would think the DCDA might be more because they're not all, but many of them are non-identical, and so you've got different immunological loads there. But I absolutely agree that monochorionic twins are trouble, and they have so many complications of that shared placentation that I think could also lead into higher preeclampsia rates. So and that's probably why there's kind of competing findings of the differing studies, because actually there's competing sets of risks there. But one way or another, and I run the twins clinic at our hospital, I say to mums, you're here in this special clinic because everything that can happen to single baby pregnancies happens to twin pregnancies, except it happens more often. And for certain things with twins, like when they're sharing a placenta, there are also extra things. So we need to take good care of you, and we need to take good care of the babies, and that's why you're here. So yeah.
Prakash, can I say something here?
Yeah, sure.
Something that comes to my mind with MCDA twins, the placental remodeling of the myometrial part of the spiral arterioles would be a little compromised, and that could be the reason why we will have an early onset one. While with the DCDA, there's a large placental base, there's a good remodeling, and it would happen late onset preeclampsia.
Absolutely.
My thinking, I may be wrong.
No, I agree with you. This is what I've seen in my patients also. That whenever there is an MC, there is a early onset. Whenever there is a DC, generally it's a late onset.
Yeah. But there is some hypertensive thing which will happen. Very rarely they will remain normotensive.
Absolutely. From mild to very severe, anything can happen. Yeah, thank you for that comments. Okay. Now the next question. Yes, again to Girija only. How to interpret S-split PLGF ratio in multiples?
So in multiples, it's all going to be a little high. And therefore, the cutoffs would have to change. Maybe we can consider 38 as a cutoff here. Less than 38 to be the cutoff, maybe. But many times with S-FLET PLGF ratio, Prakash, I would say that serial interpretation would then be able to really guide you correctly. And you shouldn't just depend on this ratio. There are so many other factors which you'll have to factor for in multiple gestations. In my experience, I've found that S-FLET PLGF ratios really haven't helped in multiples to take a decision. It's always been the clinical decision which we had to take
Absolutely.
because of the patient's presentation. And I have also experienced prenatal, that is pre-birth, pulmonary hypertension presenting in multiples. So by the time my S-FLET PLGF ratio came, for this reason, I had to take the patient for a delivery or something happening to the fetal condition, or maybe the NST not being reactive. So such reasons have happened, or maybe some beginning of a placental abruption. So S-FLET PLGF ratio interpretation, I would not be able to answer this extreme dogmatic like this number and that number would help us to make a diagnosis and interpretation.
Professor Hanan, your comments?
So for me, yeah.
Yes.
You go.
Oh, for me?
Yeah. Professor Hanan.
Yeah,
Okay. Professor
I mean,
Henry.
I agree that I have to say, I don't use a PLGF ratio for everyone anyway, because I'm very used to, look at the clinical picture. If after you've had a good clinical workup, you're still unsure and you've got access to the ratio, by all means use the ratio. And so, yeah, for twins, I don't usually find that it's adding to, my diagnosis or my management. I think if you've got a normal number, like if you do it and the number's normal, even with multiples, sure, it's normal. It's a lot higher with the higher cutoffs, though. Yeah.
Yeah, Professor Hanan, would you like to give any comments?
No, I think what Professor Henry has said is exactly right. And it's just, I think I'll just add that it's more complicated with 2 placentas, given PLGF is probably being released. So not as simple to dissect.
Yeah, so what is
Prakash, can I say something?
Sure.
I would say that still we would want to depend only on PLGF as to guide you, that you have some time or not.
Absolutely.
I just don't like that ratio anymore. I don't do it. I only do PLGF. And that gives me an assurance. I can tell my patient, oh my God, now everything's going well, let's wait. Oh my God, there's a problem, we will decide. And then the clinical course will decide the decision.
Absolutely.
But, yeah.
Absolutely. Ultimately, it is the clinical course and the clinical factors that are going to make you take a decision.
Correct.
Okay. Now, what happens in the twins is that they have both higher levels of S-FLET and PLGF.
Correct.
S-FLET increases much more than the PLGF. So that's why the ratio is higher. And as a result of this, the standard cutoff for pregnancies will not be valid. And we may have to use a cutoff of 85 or even as high as 110, which could be appropriate. Okay, now we get our dessert in. Dr. Renuka, how do immune disorders affect placental function?
Sir, Dr. Renuka has to leave.
Sorry?
Dr. Renuka had to leave, sir. She had a prior commitment. And so if you could wind up the panels.
Yeah, okay. So, okay, Professor Natalie, could you tell that? Could you answer this question?
How do immune disorders affect placental function? Yes. So immune disorders, as I talked a little bit earlier about, basically the maternal immune system is going to be dysregulated. And so it can impact things, as you've got on the slide here, antiphospholipid syndrome, and that will create those placental thrombus or the tissue infarctions. We know that this also results in preeclampsia and fetal growth restriction. Lupus, for example, as you have on the screen, that's a very complex immune disorder, and really underlying that is this really aberrant inflammatory process. And so we know that that also is a key factor to drive the pathogenesis of preeclampsia or fetal growth restriction, and ultimately can end in stillbirth. And so there's many therapies that you can use, immunosuppression, but other biologic therapies, which would be quite helpful in that situation. And yes, again, with alloimmune disorders, again, you've got the issue of recurrent miscarriage, and so really need to modulate again that maternal immune system to protect, I guess, the pregnancy and the fetus. So the placental dysfunction ultimately is happening because of these mismatches in the immune system and the placenta.
Absolutely. So most of the immune disorders, that's why require either a low molecular weight heparin or immunosuppression by hydroxychloroquine. Any of the two may be able to help us.
Yes.
The next question, we go further. Okay. The last question to Professor Henry. What are the newer developments, both in clinical practice or on horizon?
Okay. So look, let's just start with the simple stuff. I remember you were saying earlier, Prof. Mehta, that we want to make sure that regardless of setting, that we're delivering what we can and that we're doing the simple stuff. So the three pillars of preeclampsia prevention for clinical practice: aspirin, and making sure that however you screen, you're getting women into care early, before 16 weeks, so that they can be started on low dose aspirin at night, before by 16 weeks, if at all possible, and that will help preeclampsia, also probably fetal growth restriction type syndromes and other the other obstetrical syndromes as well. Calcium, for those who've got low dietary calcium, it's a bit controversial, but look, it's a low cost, easy to implement. And exercise is something that we really forget. And there is, yes, they're not randomized trials, but there is evidence from cohorts and case controls that regular exercise, just sort of 150 minutes a week or more of moderate aerobic activity will decrease hypertensive pregnancy, it'll decrease diabetes, makes you feel better. I say to my patients all the time, exercise, you just have to take exercise regularly. You don't have to take it seriously. And yeah, so those are kind of the three things that we can absolutely do now. Then in terms of what might be on the horizon, you've got them up on the screen. I don't think any of them are ready for prime time yet, but there are the various, obviously, the next generation worth of biomarkers that we're doing the studies on, in terms of how useful are they in clinical practice. And let me tell you, anybody who actually manages to get something that will predict term disease well, and something we can do about term disease, is going to make their name forever, because although the preterm cases are very striking, the term disease is actually the bulk, and the longer term maternal cardiovascular, diabetes, etc. It's all from that. Then there's as it says here, imaging and diagnostics. We're also trying to work out better ways, as I guess Prof. Kingdom was talking about in his talk as well, as how do we actually translate what sort of in the pathology lab we know about poor placentation in preeclampsia into actually being able to pick it up clinically in a way that we can use. So those are, I guess, that's a combination of, all right, let's get simple stuff right now, and then develop what we can on the horizon. And I don't know whether Natalie wants to add in any of her group's work there additionally.
No, I think you summed it up perfectly, Amanda.
Can I add something, Prakash?
Yes, please.
Yeah, we are talking of a lot of screening and estimation and everything. But what when the disease actually happens is something where we need to really look into a little more closely. And I think plasmapheresis, then complement clearance, and all these things are sort
Going
of
to come
new
in a
things
big
which
way.
are coming up, and they would be helping us in a big way. I have seen with patients of autoimmune disorders, as we can give them some, some sort of modulators before they get into conception. They have helped to an extent, of course, not very robust data to support such kind of thing. But all the same, these are the various things that we will also have to look at, because I think somewhere we go back into focus of screening and trying to predict and detect and all that. But what when it actually happens is a very big gap that we need to close down.
Absolutely.
Actually, that is a really good point. And
So probably, yes, please.
I'll just really quickly add that as Amanda was probably alluding to, my team are very focused on repurposing therapies for treatment, which is what you're saying. Once it's happened, we need to actually be able to help these patients. And we're looking at biologic therapies, which will suppress certain aspects of pro-inflammatory or too much inflammation. And so we'll hopefully have some nice publications coming out shortly. And also looking at developing targeted therapy to the placenta to shut down the production of SFLT really early on.
Absolutely.
And making sure that we stop the disease at its source if we already know the disease is there. So I think that's a great point.
Another thing which we, if I may say, I'm sorry. Another thing which we found is rather than going for a BNP, a high sense troponin I would be a better marker to be able to differentiate, especially in this condition for cardiomyopathy and all.
Absolutely. So we are going to hear more and more about various kind of multiomics and the trophoblastic stress assays in future. We are going to use MRI more for placental delineation in future. And our old uric acid estimate is again coming back in a big way as a marker for oxidative stress. As far as therapies are concerned, like it was already brought out, SFLT1 inhibitors, the gene therapy, the stem cell therapy, the statins, the exosomes are all likely to come in. And there are a lot of studies going on, preclinical studies are going on nanomedicine, which could go directly to the placenta and affect only that particular portion. And I'm sure in the next decade, we are going to hear more and more about nanomedicine. So to conclude, while there is no cure for placental dysfunction, early risk identification, prophylactic medications like aspirin, regular monitoring and timely delivery form the cornerstone of the management. Emerging therapies hold promise, but are not yet the standard of care. So thank you very much. While we, even in a low resource setting, we definitely need to aim for the moon, because that's the only thing that will bring down our maternal mortality. And thank you very much for being on the panel. All our panelists have done wonderfully well. Please give them a big hand.
Thank you. Thank you. Thank you. Thank you. Hi, Shaswati, Revati.
Hi.
Anu, Sunita. Hi.
Thank you very much, sir. Thank you, madam. Thank you, everyone, for such a active participation. And I request all of you to please stay for our next update on what's new in the PENAI program. Here, I'd like to welcome Dr. Revati, our Secretary of SMFMI, the Chief Consultant and Managing Director, Mirror Health Visvesvaraya, Bengaluru. She's been the Indian co-chair of PENAI, Organizing Secretary at iShip World Congress 2023, International co-chair iShip 2025 to be held in Chicago next month. She has many awards and publications to her credit. Thank you, madam. Here I also welcome Dr. Shikha Malhotra from Quidel Ortho, who are partnering with us for the PENAI SAARC, SAARK, RC. Thank you, madam. Over to you.
Thank you so much, Akshita. And taking this program forward, we know that preeclampsia education of the nation, India, has been the flagship project of the SMFMI, as our president, Dr. Prakash Mehta, has just made an announcement that preeclampsia is the #1 cause for maternal and perinatal morbidity and mortality in our country. And I would not be wrong if I say it's happening worldwide. And of course, from the SMFMI, we have been making an honest attempt to educate and empower our clinicians and also take the patients along in our effort to reduce this burden in our country and beyond. So what is this preeclampsia education of the nation, India? Next slide, please. This is our flagship project, and the Indian co-chairs include Dr. Prakash Mehta, who's the president of SMFMI, myself, the secretary, as well as Dr. Sarosh Rana, who's the current secretary of the iShip, and she has been our international advisor. So PENAI is a collaborative project between the SMFMI and the iShip, and it involves certain learning modules which are updated based on the latest evidence-based research. to educate and empower clinicians from across India. And this is the first ever formal certification course with the collaboration from the iShip, which SMFMI has started, which has gone a long way to certify clinicians for preeclampsia education. Next slide, please. Now, what's new? This is something that we include in every episode of the VLSPE, because PEN is the backbone which got us the VLSPE. Basically, VLSPE is an academic program or initiative of the PEN project to get everybody involved. And this is coming absolutely free without any registration cost. And this is also, the links are also uploaded on the iShip website for access of this particular program from people across the world. Next slide, please. Yes. So basically, PENI is transforming preeclampsia care in India. So it's a collaborative effort between the SMFMI and iShip. It's a hybrid education model. So we have both virtual as well as on-site training. It focuses on high burden regions in India and neighboring countries. And we've had about 951 healthcare professionals empowered till date. Next slide, please. So what has PEN done to us? So it has ensured 35.4% certification rate for the 6-week online course, 69.1% certification rate for one-day on-site workshops, 94% rated the course as excellent or good, and 88% reported positive impact on clinical practice, which is really reassuring. And SMFMI is now engaging itself to collect a clinical survey based on what PENI has impacted on their clinical practice after the clinicians have been certified from PENI. Expansion efforts in SAARC, countries of SAARC, African and South American regions is ongoing, and it has a potential to become a global template for maternal health education. Next slide, please. Now, we are very glad that the abstract based on PENI has been accepted at the iShip 2025 World Congress Chicago for an oral presentation. And we are also very glad that, we presented this data in 2023, and we've moved, beyond that now to reach newer heights, which is going to be presented at the iShip World Congress. And beyond that, we would want to publish this so that, it becomes a template for maternal health education worldwide. Next slide, please. Now, what is PEN-SAARC? So this is again the SMFMI and iShip collaboration. It's a landmark initiative. It's a first formal collaborative course with standardized certification process for preeclampsia in SAARC countries, mainly involving Nepal, Bangladesh, Maldives, Bhutan, and other LMICs. Objective is to enhance preeclampsia education, certification, and management in high burden regions. Next slide, please. Now, this is definitely going to impact high burden regions. There's going to be standardized education. The PEN core team from India leads expert-led training and certification. Global reach, targeting SAARC countries and other NMICs with high preeclampsia disease is our primary intent. Transformative impact, improve maternal health outcomes, reduce mortality, and promote best practices in preeclampsia management. And our knowledge partner for this venture is Quail Lortho. And thank you so much, Dr. Shikha Malhotra, who's actually joined us today. And I'm sure, PEN-SAARC is going to be highly impactful in the future. Next slide, please. Yes, this is a quick slide which I love to present each time. This is what PEN has done from 2021. We launched this during the World Preeclampsia Day. PENI initiative was launched on the 22nd May 2021 on World Preeclampsia Day. And this started off as online virtual training modules. Beyond that, we had the VLSPE series, which was actually set up in 2022. I'm so glad that we've had 2 series with 6 episodes. This is the 12th episode that's happening. And this is coming absolutely free to all attendees. And this covers attendees from across India and faculty from India and abroad. iShip World Congress came to India because of the PENI initiative. I'm very, very glad that we had about 400 plus attendees from about 30 countries to discuss about preeclampsia. And I'm so glad that the faculty who actually presented today were all there for the iShip World Congress. Next came the TNFOG state level workshops. So we presented in state level workshops, and that had a massive 88% certification rate in Tamil Nadu. Beyond that, we actually visited several medical colleges, several academic bodies, carrying PEN on an on-site format. And this had a very good result, and we had about 88% certified through the on-site courses. Beyond that, we also moved on to the webinar versions. We had a massive webinar, which actually happened in the December of 2024, where we had about 151 attendees, all clinicians from across South India, out of which we had about, I think, close to 80 certified for the course. And certification involved a pre-test, post-test format where the attendees had to secure at least 75% to graduate. So that was a big number, but in spite of this, we had lots of people certify for the course. Then we also provided the iShip World Congress updates to everyone. The recordings of the iShip World Congress were circulated to everyone who attended the PEN course, and this actually proved as an essential update of what was happening newly in preeclampsia. Then we actually got the preeclampsia, a dedicated textbook on preeclampsia, which was released globally in April of 2025 during the SMFMI annual meeting. It had a soft release during the Sydney ISOM-SOMANS Joint World Congress. So that was when we had a soft release, and then we kind of released the book now. And this has been receiving is being well appreciated throughout the country. Beyond this, we want to move towards PEN-SARC, moving out of India, though we've had people from Bangladesh and Afghanistan register to our courses remotely, but we want to do this in a more structured format. And ultimately, we also want to involve a lot of patients into this program through the Suraksha PE program so that we can build support groups in India, just like what's happening in the rest of the world today. Next slide, please. So this is a graph just to tell you what PEN has done, and we've had about 951 delegates who've actually participated in this course, and we've had close to about 620 who've certified, passing the post-test. Next slide, please. Yeah, so we also run what's called a virtual interactive session, which happens once in 6 months. And this actually has been chaired by Dr. Sarosh Rana as well as the Indian co-chairs. And this aims to address the clinical problems. It's not just about learning the modules, it's also about posing the real life situations which are answered live. And this has also led to what is called the guidance SMFMI email. So we've been receiving queries on the SMFMI guidance SMFMI email based on preeclampsia, which we've been answering and sending references to clinicians from across the country. Next slide, please. Next slide, yes. So future programs, PEN-I webinar version is planned for recruitment 4 zones across India. We've done that successfully for South Zone. We want to do it next to the North Zone. PEN-SARC is the project in the pipeline, and we are open to setting up workshops in medical colleges and academic societies. We need a minimum number of 50 clinicians to participate. We've also run workshops for nurses and Ayush doctors, and we would want to structure more of these courses to not just the clinicians, but also support staff who are actively involved in the management of preeclampsia. PEN Global, yes, we propose to move towards Brazil and other African countries under the leadership of Dr. Sarosh Rana. Next slide, please. So what is PEN Advanced? Now we have something called the PEN Advanced Initiative. So this is empowering change through research. PEN Advanced trains delegates who have completed the PEN-I basic course in implementational research, which is, I think, something that we have to move ahead, who have and this is to drive evidence-based practice and policy change, revolutionizing preeclampsia management in high burden regions like SAARC countries and other LMICs. Next slide. Yes. So with this, I wouldn't say I'm ending this. I'm just, putting a platform to start newer initiatives, and hope to meet you all soon with some more newer progress that PEN does, and hoping that our global ambition to navigate across those countries with a very high risk disease burden, materializes and we are successful. Thank you so much. And with this, we also thank the entire core team of SMFMI as well as the PEN-I core team who've been always there to support us to take this initiative across India and beyond. Thank you.
Thank you, Dr. Revati, and thank you, Dr. Shikha, for being with us. Now, I'd like to invite Dr. Sunita Mahesh, Senior Consultant, Maternal Fetal Medicine and Medical Director at Milan, the Fertility and Birthing Center, JP Nagar, Bengaluru, to talk about her experience and present her study, which is placental pathology in PE. Her special interests are in high-risk conceptions and management of recurrent pregnancy loss. Welcome, Dr. Sunita, madam.
Yeah. Good morning. I thank the organizers for giving me this opportunity to give my insights about this study article, which was authored by my student as well as my patient. She was a patient of preeclampsia who went on to do her PhD, for which I was the co-guide. So this is a comparative study on morphometric and histological features of placenta in IVF and in natural conception. So actually, like how it has already been explained, IVF conception actually comes under, under a score of 3 in Gestosis score for preeclampsia. Here we have just done a basic study on the placenta of patients who conceived through IVF and compared with the placenta of patients who conceived naturally. Here we have actually taken only the normotensive patients in order to understand whether the score of 3 given by Gestosis is valid. So next slide, please. So we all know that placenta is a vital organ which acts as a substitute for immature fetal organs, and it directly interfaces between the maternal and fetal circulatory systems. The pathological changes can significantly impact the fetal outcomes. Examination of the placenta helps to understand the prenatal experience and also have an insight to the obstetrical complications like hypertension, fetal growth restriction, and premature birth. It also helps to guide the future pregnancies by giving an insight from the clinical management protocols which was used. IVF is associated with increased risk of placental abnormalities and placental related complications. This study aimed to compare the morphological and histological features of placenta of IVF pregnancy with those of natural pregnancies. The complications have already been discussed in our presentation today, right from Professor John to the panel discussion, in which we had the very good panelists discussing about all the problems. So the next slide, please. The IVF pregnancies are known to have complications because of certain influencing factors like the ovulation induction drugs, the in vitro culture, embryo freezing, and the impacts could be on altering the endometrial receptivity due to genomic changes or metabolic changes, the structural abnormalities in the placenta, vascular changes, and also because of the epigenetic regulation of the placental function. So next slide, please. Here we have done the morphological comparison, the histological examination, and also looked at the fetal growth impact. Next slide, please. This is the table which shows the comparison between the morphological parameters. The mean gestational age at which the delivery happened was also significant. The weight of the placenta in IVF pregnancy was lesser as compared to the natural pregnancy. The diameter of the placenta was less. Thickness of the placenta was also increased in IVF pregnancies. The number of cotyledons, not much of significance in terms of p-value. The birth weight, definitely there was a significant difference in babies delivered through IVF conception versus babies delivered through natural pregnancy. Next slide. So it was already explained about the various abnormalities in IVF pregnancy placenta. All these various implantations or various attachment of the cord did have a significant p-value. It was central in only 3 IVF pregnancy patients as compared to 8, eccentric in 18 versus 38, marginal in 19 versus 4, velamentous 10 versus 1. So the overall p-value was less than 0, was about 0.001. There was velamentous the velamentous insertion also was more in the IVF pregnancy group. Hematoma was more, accessory lobes were almost same, the bilobe placenta remained the same. Next slide. So histology also, in the histological comparison, the calcifications were more in IVF pregnancy, infarction, stromal fibrosis, syncytial knots, fibrinoid necrosis, and the DVH, distal villus hypoplasia, was seen specifically in IVF placenta. Next slide. So this is the histological findings of IVF placenta. There was calcification, infarction, and then stromal fibrosis with Masson's trichrome, syncytial knotting, distal villus hypoplasia, fibrinoid necrosis. Next slide, please. So basically, this is all because of the hormonal levels altering the endometrial receptivity and the embryo implantation, disruption of the circulation or metabolism, and also resulting in fetal placental circulation pathological changes. Next slide. So in conclusion, IVF placentas have shown higher incidence of cord insertion abnormalities, increased thickness, low birth weight, and more calcification, syncytial knots, and fibrinoid necrosis. These differences can contribute to adverse pregnancy outcomes. It lays the pioneering cornerstone for future pathological studies on preeclampsia in patients undergoing IVF, given the increasing number and complications of IVF pregnancies. Thank you.
Thank you very much, madam, for an insight into your study. Now I'd like to invite our PENAR organizer, Professor Dr. Munikrishna sir. Sir is Professor and Head of Department OBGYN, Sir Devaraja's Medical College and Hospital, Kolar. Sir has 30 plus years of experience, has been an undergraduate and postgraduate examiner, and has several awards and achievements. And Sir's special interest is in high-risk pregnancy care and delivery. Over to you, sir.
Good morning, one and all, and participants, and especially Professor Prakash Mehta, who's with him, long association with him as friend of me, and Preeclampsia Education of the Nation, India, PENI, this certification course we had come across, and we came to know, and we are in the process of enrolling for the program. Ours is a tertiary care hospital and Sri Devaraja's Medical College, RL Jalapa Hospital. And we do get a lot of preeclampsia, eclampsia, HELP syndrome cases referred from tertiary, from the periphery across not only from Kolar and Karnataka and neighboring Andhra and Tamil Nadu. And we do a lot of cases, and we manage in intensive care unit, and lot of we are managing in intensive care units. We lot of progress we have made, and lot of we have saved mothers and as unborn due to preeclampsia, eclampsia. And with this program, I think it is very good certification course, and by the stalwarts like Professor Prakash Mehta, co-chair of India, and Dr. Revati Rajan, and a lot of speakers from India as across the international level, whose experience and will definitely help us to go through this updated knowledge, as well as to manage well all these burden of eclampsia, preeclampsia cases. And as all of us know that we don't know specific cure for preeclampsia, only the prevention, early diagnosis, and management of preeclampsia, eclampsia will definitely help to decrease mortality and morbidity of mothers as well as unborn. I think it's a boon, this PENI certification course, for all practicing obstetricians, postgraduates across India as well as globally. And definitely it'll help us to manage and well with updated guidelines as well as with definitely will decrease the mortality and morbidity due to preeclampsia, eclampsia. I think, thank you, Dr. Prakash Mehta and organizers give me the opportunity to speak about PENAI program. I think Dr. Revati Rajan has elaborately told about the program as well as the progress, new progress through the SAARC countries to expand this program. Thank you, Ananda.
Thank you very much, sir. Now we're moving on to the vote of thanks and closure. It's my great privilege to deliver the vote of thanks at the end of this enlightening academic session. This is our 6th episode in the 2nd series of the virtual learning series. First, I would like to extend my heartfelt gratitude to our esteemed speakers for sharing their valuable time and insights with us on placental role and dysfunction and preeclampsia. The knowledge and perspectives provided today have truly enriched our understanding and inspired us to continue our learning journey with enthusiasm and dedication. It was great to see that it has been accepted by many delegates across the country and worldwide who have joined us virtually today. We're excited about SMFMI growing across the globe. We thank our sir, Dr. Prakash Mehta, whose vision, constant support and guidance has brought us this far. Dr. Revati, whose hard work has made SMFMI grow leaps and bounds. I'd like to thank Dr. Revati for giving us coordinators this opportunity to work for SMFMI and encourage us to be involved in various academic activities. We'd like to thank wholeheartedly PENAI Global Co-Chair, Professor Dr. Sadosh Rana. We deeply appreciate Professor Dr. John Kingdom for this exhaustive description on placenta and PLGF testing. I thank the Australia Preeclampsia Network leadership for partnering with us for the SIG HTP PE. I thank all the eminent panelists and for their seamless discussion and sharing their extensive experience with placental dysfunction. I thank Dr. Sunita, Dr. Munikrishna sir for the update. As we bring this wonderful event to a close, it's my honor and privilege to extend a heartfelt vote of thanks to the amazing team who made this possible. Team Shield Connect, a knowledge partner and their members, Mr. Balaji, Vice President at Shield, Mr. Sriram, our regional coordinator, and Ms. Chitrakala and Sahiti Priya. Very importantly, I'd like to thank our EC members of SMFMI for their hard work, dedication, and passion. A special mention goes to the behind-the-scenes staff, our staff, Mr. Rajgopal and Dr. Meghna Srinath, who ensured every detail is perfect. They are our pillars of strength and have worked tirelessly, meticulously, and ensured that everything runs smoothly. Your efforts truly reflect the commitment you have to our society and to making every event perfect. Lastly, I extend my gratitude to all the delegates present here for their active participation and attention. Let us carry forward the knowledge we have gained today and make the best use of it in managing our patients and saving lives. Once again, thank you all for being here and making this session a great success. Thank you very much.
Thank you.